Thank you so much. Please have your seats. I'd like to welcome the Managing Director of Nigeria Health Watch, Vivian Ihekweazu, who will be giving us the opening remarks for this morning's event.
Good morning, ladies and gentlemen. Thank you all for being here this morning and for making it on time. My name is Vivian Ihekweazu. I'm the Managing Director of Nigeria Health Watch. And I welcome you all this morning to our Health Watch Policy Forum titled Decentralising Health Security, Lessons from COVID. Oops. Sorry. On behalf of my team, I would like to welcome you all this morning to this event. And I'd also like to welcome our distinguished panelists and guests who are here with us today. We're very honored that you agreed to come, and we're equally honored that you have all said you spend the time this morning talking about this very important issue of health security. Just so we know who is in the room and just to welcome some of our panelists and so you know who we have here with us today, I'd like to first of all welcome Dr. Morenike Alex Oko, the Director of Public Health, Director of Public Health at the Federal Ministry of Health. Dr. Ifedayo Adetifa, he will be joining us online this morning and be giving his keynote speech virtually. We have with us this morning Peter Hawkins, the country representative for UNICEF. We have with us Dr. Festus Shoyinka, Director of Public Health, Ogun State, at Federal Ministry of Health in Ogun State. We're waiting for the director from SFH, Dr. Omo, but I think he said he'll be on his way. And we have with us Dr. Emmanuel Agogo, the country director for Resolve to Save Lives. You're welcome. Dr. Anne Ada Ogom, Head of Policy Private Sector Health Alliance of Nigeria. Dr. Alaolu Aderinola, Head Response Division, Department of Health Emergency Preparedness at NCDC. Ninyola Williams, Managing Director, Drasa Health Trust. Dr. Yahya Disu, Director, Risk-Coms, NCDC. Mr. Aliyu Israel, National Lab Manager, Cleaner Lancet Laboratories. Plus, of course, our two moderators for the two sessions, Dr. Ifeanyi Nsofo, Senior New Voices Fellow, Aspen Institute, and our Director of Programs. Director, where are you? There you are, Dr. Kemi Abaoye. So, health security, this is one of those topics that I think has really, really risen up in terms of discussions and priorities globally. And we all know why that is. We're well aware of the significant impact of COVID-19. And if we can imagine that really in the last 2 years even, we've lost over 6.3 million people globally. That is a phenomenal figure and a significant loss of life. And each of those lives lost is a life lost to families, friends, etc. And yes, we may have kind of taken down some of the restrictions in many countries, but COVID is really far from over and really remains a topic that has catalyzed many discussions globally about how we strengthen preparedness. Collectively, none of us is safe until every country is able to strengthen their own individual health security. And it's led to a lot of reflection and lessons learned. And how do these lessons learned inform how we collectively respond to current and ongoing and future infectious disease outbreaks? COVID-19 really hit us hard. We know this is not the last. We're currently battling monkeypox in many countries. Nigeria was unfortunate to have an uptick in cases in 2017, and since then, countries in Europe, USA, etc., are now experiencing rising cases of monkeypox. In Nigeria, we know we are faced with a multiple burden of many infectious disease outbreaks, from cholera, Lassa fever, etc. And we know when COVID-19, the pandemic started in Nigeria, we were faced with knowing that we had very weak health systems. And at that stage, nobody quite knew how the country was going to respond. And as we saw, there was a multi-sectorial response with leadership from the Presidential Task Force and operational response through NCDC, our Public Health Institute. And that really saw national structures provide capacity, both at the national level and at the subnational level. We saw the rollout of labs very quickly to ensure that where people need to be tested, they could get tested. Financial assistance was critical in enabling the response. The UN One Basket Fund, they came together and supported the government of Nigeria. In addition to the World Bank providing financial assistance, public health financial assistance to the states. And of course, the private sector really came together, and we saw that through coalitions like CAR-COVID. But also, beyond CAR-COVID, there were other private sector institutions that came together to support the response, both at the national and subnational level. And many of them were to alleviate some of the really catastrophic hardships that many Nigerians faced. However, we know that given our federal structure and the decentralized decision-making processes we have, led by state governors, this has been and continues to be an inherent challenge and really is a weakness in monitoring and implementation of, for instance, IHR. So this was really the genesis of why we thought it's important to, yes, discuss lessons learned, how did we respond as a country, but how can we also have that discussion about not just our national health security, but our subnational health security, where we know was not as strong as it could have been. So really through the two moderated panel sessions and the speakers who you will both listen to, both Dr. Adetifa and Peter Hawkins will give really two overview speeches. We will really discuss the response structures that were deployed at the national level and really what are the lessons learned and application really at the subnational level. We'll look at this from a perspective of things like points of entry, risk communications, IPC and health facilities, and also looking at state-specific responses. For example, Ogun State, where the index case of COVID-19 was first reported. And then we'll, of course, hear about the important role of the private sector in building sustained partnerships for epidemic preparedness response in Nigeria, as well as sustained funding structures, especially, again, at the subnational level. COVID-19 has really shown us the importance of strengthening global collaboration structures. So in strengthening global collaboration, we're also looking at how regional structures were also strengthened through the COVID-19 pandemic. We saw organizations, institutions like Africa CDC really take that regional responsibility for supporting the response on the African continent. This was done through the procurement of diagnostics, setting up of the African Vaccine Acquisition Trust, procuring vaccines through Johnson & Johnson's, and really strengthening sub-regional institutions like WAHO as well. And of course, national structures, national institutions like NCDC, MPA, CDA, etc. And all of these national structures were there to support the subnational, all laddering up to the global health security agenda that Nigeria, like over 70 countries, has committed to. So through this policy dialogue and through the discussions, we will have Q&A sessions where you can ask some of the speakers and moderate, and through the moderated panel sessions, questions that really we need to interrogate in terms of strengthening our collective national and subnational health security. And we hope that through this platform, we can discuss lessons learned from the COVID-19 response, in addition to exploring new and existing response structures and how they perform through COVID-19 and what can we learn in responding to ongoing and future epidemics and pandemics. And of course, we'll explore the important role of the private sector. I think the private sector really showed us what capacity they have, both in terms of financial, but in terms of resources, and also the fact that collectively, the private sector was negatively impacted by COVID-19 through the economic losses that they faced. And that really shows that the collective responsibility that the private sector has and the capacity that they can use to support in strengthening health security structures, both at the national and the subnational. And we'll also discuss how capacities were built and how these can be sustained going forwards as a country, and how we can use these as lessons learned to strengthen our national health security. So with that, I will pass it back to the moderator, Kemi, and thank you once again all for being here this morning. I'd like to also welcome Dr. Udoho, Managing Director of Society for Family Health. You're welcome, sir.
Thank you so much, Vivian. And thanks, everyone. Thank you, our esteemed guests, for being with us this morning. So very quickly, we'll move to Goodwill Messages. And to start this off, I'd like to welcome Dr. Patrick Nguku of AFENET to give his Goodwill message really quickly. Thank you. Please put your hands together for Dr. Patrick.
So good morning, everybody. I would like to thank Nigerian Health Watch for inviting AFENET to this very important policy dialogue. I think there's no better time than now to discuss how to decentralize health security. I'm just hoping that we will think together how to continue the peacetime investments that we need to continue making on important foundational capacities in detection, in confirmation, in notification, but also investigation. Work that NCDC has continually done in terms of strengthening the surveillance and response architecture, not just nationally, but subnationally and at the community level. The other point I want to bring up is there is a very nice document supported by, developed by government with support from UNICEF, a policy and a framework for community health that defines some of the steps towards strengthening the structures and investment at that level. Because as we all know, we will not achieve health security if we don't achieve universal health coverage and have a robust primary health care. So I'm really looking forward to the discussions and to implementing some of the decisions that are made here. Thank you very much.
Thank you so much, Dr. Patrick Nguku, the Country Director of the Africa Field Epidemiology Network, AFENET. Thank you so much, sir. Next, I'd like to welcome Dr. Njide Ndidi, who is the Country Director of Farm Access Foundation, for a quick Goodwill message.
Thank you. Good morning, all. I wasn't expecting to say anything. I just came to listen. But I think, first of all, to thank Nigeria Health Watch for inviting us. Farm Access Foundation was very involved during the COVID-19 pandemic, and the realization that our support was very reactive was, a turning point for us, and also should be for the country. The fact that we should already be proactive in terms of putting in policies in place to fight pandemic. I think it's a wake-up call, and in our work supporting state governments to strengthen health systems, there's no better time now than to discuss health security. So I'm really looking forward to this. Also to find a way to support at the national level in terms of policy. As the last speaker mentioned, you cannot achieve health security without universal health coverage. But it's important to ensure that at least there are policies and procedures in place so that we even know what to do. So again, also from the point of view of the Healthcare Federation of Nigeria, which I am the vice president, we saw the power of the private sector. The private sector is there to help. They have tremendous capacity, but they need a coordinated mechanism to be able to deploy their resources. During that pandemic, we were scrambling. Private sector had a lot of resources to put in place, but we didn't even know how to support. We were scrambling from federal ministry to state government. So again, these are some of the areas that we're hoping that there will be a coordinated policy document or instrument or some kind of mechanism where private sector can plug into supporting health security. So anyway, having said that, I'm very much looking forward to hearing the dialogue and looking at how we as an organization can support this effort. Thank you.
Thank you so much, Dr. Njide. Really looking forward to the discussions that will be had during the second panel session. That's where the private sector investments will be discussed in detail, and we have an excellent lineup of speakers for those. Thank you. Next, I'd like to invite the Director of the Department of Health Research and Statistics at the Federal Ministry of Health, Dr. Ngozi Azodo, for a Goodwill message.
Thank you very much. I think it's okay for me to stand on the existing protocols. And I want to wish everybody happy welcome back from Salah and from the holiday. So much has happened since 2020 and nobody needs to be told. So I think having a dialogue, a policy dialogue that is looking at decentralizing health security, lessons from the COVID-19 response, is so key. I'm sure that so many people have, in the course of this meeting, we'll hear a lot about health security, what has happened, what happened during the COVID, and some of the responses that people gave, and the system responses that have taken place. But I think that since I'm not going to be here all through, this gives me an opportunity to first appreciate Nigerian Health Watch. I came here because I always have to honor their invitation. There is a special group of people who have done so much for the health sector. So can we please appreciate them? Also, because I'm supposed to be declaring a meeting open on behalf of the Permanent Secretary, so I want to upfront crave your indulgence that I leave early. But some of the things I would like us to put on the table is looking at what really works. First, what works? A number of things works, and we can list all of that. We see the opportunity to begin for the first time to coordinate our responses. We're not yet there, but we started well. We also saw the impact of the private health sector that has already been spoken about. And I'm sure going down the meeting, we will also hear more on that. We also saw the incredible way the NCDC responded, and the government also was able to put in a lot of infrastructure in place within such a short period. So it is possible to have that happen. Of course, such huge expansion comes with a lot of problems. So we need to be addressing that. But we also look at the issues around the institutions that coordinate, both national and international, how they relate. I remember that Dr. Chikwe used to make a lot of noise about monkeypox and all the local poxes, which didn't seem to be anybody's business until it went international. I think this is making me a bit breathless until it went international. So we also need to be looking at how our local institutions can be strengthened to respond to local issues, whether it is a priority to the international community or not. Then some of the issues that are also germane are the issues around human resources for health. Being that the Human Resources for Health program is bang in my face in the Ministry of Health, you see how people move. The migration, immigration is way beyond what you can imagine. So, dealing with the issues of human resources for health security must be key to what we are speaking about today. And it's gone beyond, government increase salary, do this and do that. We must begin to think outside the box. We must begin to look at how we can use bilateral relationships to strengthen human resource mobility in a way that is a win-win situation for both those who are receiving the migrants and those who from where they are immigrating. As I was coming here, I was talking to one of my colleagues, and I said, in the last 1 year or less, my sister is here, she can bear me out. They sent us high flyers, presidential award winners. There were about 6 of them that were sent to my department. There were about 8 of them that were sent. 6 have left. And 2 are on their way, like on one leg, they are doing scholarships, 6-month course here and there, and by the time you know it, they're also gone. So this is beyond what we know. So addressing the issue of health security must deal with the issues of human resource for health security. It is so key, it's so important, and it's something we must respond to. How do we respond to that? I don't know. I guess the dialogue will speak to that. But I have a few suggestions we've been working on, so we can also put that on the table. We're talking with some of our countries, the biggest countries that receive our human resources. And we are saying, can we have an MOU that tries to look at how we can, not stop people from moving? That cannot happen. It's not possible. I'm a doctor. Nobody is going to be able to stop me from living. And my kids, nobody can stop them. But we can have children, young people move in a way that benefits the country. Can we train? Is there something we can get to strengthen local institutions to train more people? We're not going to train an epidemiologist today to replace somebody like Dr. Chikwe, for instance. It's not possible. Some things come with time. But we can train people and have a pipeline of people that can meet our needs at every point in time. So, we're also looking at how we can strengthen local institutions. Some of the problems we have is the weakness of our regulatory mechanism. Sometimes when you train people very quickly and they are not well regulated, you just lose it and you are not able to control the quality. So looking at the issues around quality is very key, very, very important. And of course, domestic resource mobilization. And that's where the private sector comes in. When I had a conversation with the minister yesterday, and we're looking at how can we put health on the political agenda for 2023. I think we should be talking about that here as part of ensuring global health security, making health a political agenda. And with COVID, it should be easy, right? But it doesn't look like it's that easy after all. So mobilizing domestic resources is not just about money. It is also about mobilizing the strongest voices we had during this response, during this COVID response, so that we can find a way to put health on the political agenda. And putting it on the political agenda also will include actual money. And the private sector is so key to that. But nobody in the private sector will give you money to manage if they are not confident of your systems. So we also must be addressing the issues. How does the system that we run ensure that we have security of our health when the chips are down? And of course, surveillance is about data. So we have all these data. In the Ministry of Health, we have the DHIS2 platform, the overarching data platform. Then we have MPSCD, we have NCDC, we have NHIS, we have this. How do we work together to ensure that we have big data that responds to the Nigerian health system. So if NCDC wants something that is with the MPACDA, that will be a common platform where you can easily access what should be public information. So we must be speaking to surveillance and alignment of data, and that's part of strengthening coordination. If we don't coordinate ourselves well, we will continue to, have some of these issues. I think I'm taking too long, so I'm going to stop here. I have a very long statement that I wanted to read, but I think that others will speak to some of the things that I may have missed. But I also now want to use the opportunity to appreciate our partners, who supported us through this struggle. I don't know where we would have been without them. And of course, the private sector. I have a daughter, she's now in Harvard. When she was small, I asked her, my small baby, she said something really nice. I said, what will I do without you? She said, Mommy, you will run away. And what would we do? What would we have done without all the support we got? Well, my answer to her was, thank God you are my daughter. Now I don't have to run away. So thank God you are there for us. Now we can take it as given that going forward you will support us. Thank you very much and God bless you. Good morning.
Thank you so much, Dr. Azodo. You have laid out some excellent points there that would definitely fit into the conversations when the panel sessions begin. Next, I'd like to invite Dr. Emmanuel Agogo, who is the country director at Resolve to Save Lives, for a very quick Goodwill message. Let's put our hands together for him.
Good morning, everyone. All protocols duly observed. I think after listening to just call her Professor Azudo, I don't think I should say anything. Maybe we can pack up and go, really. She's been very impactful. She's touched on a lot of the key things that we need to discuss today. I think what we'll be doing will be to really flesh out the points that she's raised. I want to also thank Nigeria Health Watch, as always, for bringing the right people, key people into the room. I think that we have ahead of us, a couple of hours of having a very impactful decisions. And I'd like to encourage us that we don't stop in just talking about the ideas, but we leave here with concrete support, concrete ideas, concrete next steps, which we can work with the Federal Ministry of Health, and partners here can also take forward. So I'll stop there so that we can carry on with the program for this morning. So thank you very much, and I wish us a fruitful deliberation. Thank you.
Thank you, Dr. Emmanuel. And finally, I'd like to invite Fritz Fonkeng, who is Technical Officer at FindX, for a quick Goodwill message.
Thank you very much. Good morning, everyone. All protocols duly respected. I work for Find. Before COVID, I'll have to introduce to people what Find is. I think COVID has given us a clear understanding of what Find is now. I think our goal is diagnosis for all. And so I'll be speaking and looking at diagnosis. I know in most of the discussions we have, diagnosis is always relegated and not properly spoken of, but I think COVID has brought diagnosis to the limelight. I think talking about decentralization and strengthening health and national systems, I think that's the way to go. That's the way to give ownership to the people. It's important that these people feel that they can own this disease. I don't think COVID is going anywhere. I also think COVID will give us an opportunity to integrate diagnosis into all other diseases and not only talk about COVID, because we have had a lot of capacity built through COVID. And so it's important while we make these policies, we should have policies that are driven by data and lessons learned. So thank you very much. I am very happy to be here, and thank Nigeria Health Watch.
Thank you so much, Fritz. So very quickly, we're going to go to what's next on the agenda, and this is the keynote address by Dr. Ifedayo Adetifa, the Director General of Nigeria Center for Disease Control, who couldn't be with us here physically, but will be joining us on Zoom. Dr. Ifedayo, can you hear me? Okay, please could you unmute your mic? Looks like he is not on mute. Not yet, sir. Can't hear you. Okay. While we try to sort that small technical glitch. No, we can't hear you yet, sir. Not yet, no. Okay, while we try to sort that out, I'd like to invite Peter Hawkins, who is the country representative of UNICEF, for a really short speech on how we can strengthen the decentralized healthcare system in Nigeria in light of COVID-19. And then we'll have Dr. Ifedayo Adetifa after that.
Great, thank you very much, everybody, and I stand on all due protocols. I'm probably more nervous today than I've been for a very long time. I've done this because I really believe what Nigeria Health Watch are doing. Secondly, preventing epidemics is our job. But thirdly, and most importantly, around decentralization and decentralized health services. It's been a theme throughout my career, both here for many years in Nigeria, in Ethiopia, Pakistan, 3 federal countries, 3 countries with very low fiscal base and complex developmental contexts. So I'll try and bring some of that experience to bear. Secondly, I think because Eduardo and Paula are away, I was asked to come and do this, so I use that to do it, but they really should be there. I think let's go back to, as the Nigeria Health Watch said, the success of Nigeria's response to COVID around the presidential task force and how they evolved, how they managed, the commitment they showed, the seriousness of which the government actually took COVID forward. The multi-sectoral pandemic response plan, which was one of the best that I've seen across the globe, and it really was an attempt to try and really do a multi-sectoral response to COVID. COVID, an incredible initiative, one I think that shifted the needle. Without COVID, I do not think that we would be in the situation, or Nigeria would be in the situation it is today. And you generously talked about the UN Basket Fund, which turned over $70 million within the first 18 months of the pandemic. We're not at the end of the pandemic. We're maybe even only halfway through. But as the point of this meeting says, we're also at the beginning of many epidemics to come. This is an alert rather than anything else. One of the main challenges we were faced with, and I was talking to many people at the time in the Presidential Task Force and others, was how do we get the states to respond? That is where the response had to come from. That is where the weaknesses were. Some states like Lagos, who had the incredible experience of Ebola, were able to respond. Kaduna, Oyo, Edo, and a number of others. Some other states just didn't want to respond. Some states, like Kano, had to respond. Had to respond when the situation became so dramatic that there was an imperative that came about. What were the 4 areas that we were trying to look at? The importance of testing. and diagnostics right at the beginning. I thought NCDC did an incredible job in getting the 36 plus, I think it's 2 or 3 laboratories up and running at a very short period of time. It seemed like eternity at that time, but when you look back, it was an incredible feat. Getting PPEs distributed to frontline workers was a logistical nightmare, but one that I think at the end of the day was done reasonably satisfactorily. And then from the 2nd of March, the vaccination program. Those are the 3 sort of areas that I think we should celebrate and focus on in how we're working. Then there's the backdrop. There was a collapse of the global initiative to work as a global team. Nationalism became the fore. The Northern Hemisphere dominated what it wanted for itself, and apartheid took place globally. It took place around PPE at the beginning. It was impossible to get any sort of supplies for a long time. It took very long to get the diagnostics material in country, and we had to fight. But I think the vaccination shows where, one, the opportunity that the world offered. It was within 6 months that vaccines became available. But then it took basically another year before vaccines became globally available. And we need to understand that dynamic to be able to take us forward. How did we do in Nigeria? And I want to say, I know Nigeria well. I've been here and I've been in many other countries of similar stature. I think what we all did collectively, and it was a collective thing, was exceptional. What we want to do today in this scenario is though look at where we can make the improvements so that the next time we can do even better. And I'm going to focus in 3 areas. 1 is around governance, 2 is around data, and then 3 is decentralized financing. All 3 lend itself to improving decentralized service delivery. In governance, we have one very large black hole. It's around accountability of the human resources. Human resources, at the moment, it's dropping. If you look at the figures from 2016, I think it is, the number of frontline workers in health is dropping systematically year on year. The types of human resources are also becoming more and more skewed away from midwives, away from nurses, more JHUs, and the CHIPs, which are probably the most proficient response to any epidemics, are still in its infancy and still moving forward. Getting the human resources right, it has to be our number 1 priority. The second, and here I'm bringing a lot of experience from my own work and the work that Ethiopia has managed to do, is looking at top-down planning and bottom-up accountability. Our governance structure here in Nigeria has very little accountability, and a bottom-up accountability is one of the more powerful ways of doing it. Looking at contribution-derived allocations, looking at the ability for the community to look at scorecards. We have the scorecards, and the scorecards work at for example, the Nigeria Governors Forum at interstate level, and that will progress further and further and will lend itself to some sort of accountability, but not enough. Citizen report cards, participatory budgeting, and an interface between the people, so it gets a responsive service rather than a service which is imposed upon the communities. Structured accountability tools are so important in any society that services are being delivered to. It will strengthen our accountability, but more importantly, it will strengthen the way that services are delivered to the people and people are able to respond to it. Too often, I get told, even before the vaccines arrived, that there's vaccine hesitancy in Nigeria. Who determines that? 73% when we polled of the people acknowledged that vaccine was the way forward. And yet all that people talked about was vaccine hesitancy. Did anyone talk to the people and understand what their needs were, what their demands were? Very little. A resilient workforce is critical to any response. Now moving on to data. Health security is all about surveillance. Our surveillance system in Nigeria has been and will continue to be very strong. However, as the COVID pandemic evolved, so the surveillance dropped quite severely. And we saw it with vaccine-derived polio, that the outbreak of polio went across to, I think it's 22 states within 1 year, and continues to be a major problem. That was the failure of surveillance itself. And yet we still were able to look at Lassa fever, look at cholera. Cholera, again, one of the surveillance worked, but our response was weak. And I think Nigeria had the highest number of deaths in 2021 around cholera. It shows the interface between surveillance and a response mechanism. And so it's to try and ensure that we have intelligent primary healthcare systems in place, that the structures are there to be able to respond to the surveillance and respond in a timely fashion. This is what we learned from the COVID response. It took us a year to really get the state level response up and running in a way that works. It took us, in actual fact, 1 year and 2 months to get PPEs into the primary healthcare centres. An incredible figure. The laboratories got PPEs within, I think, 3 or 4 months of the pandemic breaking out, but 1 year and 2 months before PPEs actually reached the primary healthcare centres. And that is too long and doesn't allow for an intelligent PHC or a responsive PHC system to be in place. Fiscal responsibility and fiscal decentralization. That is I think is a perennial problem here. And I worked a lot in Ethiopia in trying to set up the block grants that allow for services, each state to have a block grant which they contribute to, that they ensure as predictive money so that they can set up the structures which they're accountable for, that their planning has said is required to be able to respond. When the COVID outbreak took place, it was how do we get resources down to state level? First of all, one of the most prominent of our colleagues at state level called me up and said, don't give them money, it will disappear. There's no accountability for that. And I'm being very, very straight. Secondly, I think the presidential task force allocated, I think it was 1 billion per naira per state. When I last inquired, which was about 4 or 5 months ago, most of that had been unspent. I'm sure it is being looked at to be spent now, but it was at the time, at the height of the pandemic, it was unspent, it was unallocated. We have a very complex system of resource allocation here in Nigeria. The constitution is clear. It's a constitutionally derived allocation. Money goes to state level and it's allocated according to different areas of work. We also have the Basic Healthcare Provision Fund, which is about to come in and change the way we work. The Health Insurance Fund, which is now going to be a major change in the way that things work. The international community continues to be generous in its contributions, mainly now at state level. Gavi, the MOU states, the Aliko Dangote Foundation, Bill and Melinda Gates, UNICEF, and others. The UN in its entirety have contributed a lot, and the World Bank through its system through the Ministry of Finance, Budget and Planning, also at state level. But there's no coherence. There's no way that that comes together. And if you go back to where I started about top-down planning and bottom-up accountability, that planning mechanism, the annual work plan that primary healthcare system has, is too weak to ensure that the Ethiopia, the block grant is 50-50, government and others. It is very clear what the accountabilities will be at state level to meet that money. So it has increased the level of accountability to be able to ensure that we take things forward. Having said all that, those are the three areas of improvement that we have to seriously look at. I think what we can say is, when you compare Nigeria to some of the other countries, that Nigeria's response to the COVID pandemic was adequate, if not good. When you look at the figures around immunization, for vaccination, I think Nigeria now has looked at and vaccinated 22.2 percentage of the eligible population. Is 56 million doses of vaccination have been completed. And you compare that to Ethiopia, which admittedly has half the population, it's about on par. Ethiopia has vaccinated 49 million doses of vaccine. So it is on par. So there's something that we're doing right, but there's a lot of things that we could do better in. And I would suggest looking at accountability and accountability mechanisms, looking seriously at the human resources, ensuring that the surveillance system is robust, but more importantly, the response mechanism to that surveillance system is timely and robust in itself. And finally, that the finances are available at state level with accountability alongside it, so that they can plan adequately with security, but at the same time be held accountable, so whenever there's an epidemic, they can, with a degree of security, confidence, respond to that epidemic. So I want to thank you all, congratulate Nigeria on its response, but let's, through forums of this nature, continue to advocate for improvements in decentralized health systems. Thank you very much.
Thank you so much, Peter. Thank you for a very insightful speech. Looking forward to the discussions about, top-down planning, bottom-up accountability, and responsive and intelligent PHC systems. Those were very insightful points. Thank you so much. So we'll go back to Dr. Ifedayo Adetifa now for his keynote speech, the Director General of Nigeria Center for Disease Control. Hi, Dr. Ifedayo. Hi, Dr. Ifedayo. Can you hear me? Can you hear me? Can you hear me?
I can hear you.
Great, I can hear you now too.
All right, can I carry on?
Yes, you can, please. Thank you.
I understand the participants attending virtually can hear me. Are those in-house also able to hear me?
Yes, Dr. Ifedayo, I can hear you. Can you hear me?
All right, okay. Well, good morning, ladies and gentlemen. Permit me to stand on existing protocol. And also to start off by, again, thanking the organizers of this meeting, the Nigeria Health Watch, for the invitation to participate in this health security policy dialogue that has a theme of decentralizing health security and highlighting lessons from the COVID-19 response that we can take forward. I apologize for not being able to be present with you in person. I have been convalescing from period of ill health and with my state virtually. Well, and indeed nationally, we are under siege by pathogens. And if we think about Lassa fever, Ebola, monkeypox, COVID, influenza, and some of the other diseases like Marburg that made news in Ghana recently. These are all zoonotic pathogens. These are pathogens that are primarily diseases or affect animals, but have managed frequently to cross over to human beings and then, of course, develop an appetite for humans and then stay around, causing significant public health challenges. And why not? I mean, pathogens themselves, just like us humans, for them, it's a matter of survival. They want to have offspring. They want to establish themselves. They want to be successful by whatever metrics of success the microorganisms have. But what's important is that in this course of struggling to survive and thrive, like we human beings, they cause significant disruption to our way of life, including much suffering and unfortunate loss of life. So in Nigeria, we have exactly the same challenge. We've got to work hard every year to prevent and to respond to recurrent and indeed concurrent infectious diseases. So Lassa fever season ended in May. Cholera is expected to pick up as the rains come in. Cerebrospinal meningitis is coming to an end as we, of course, the rains become established. And then we have sporadic incidences of yellow fever. We're dealing with monkeypox now. We've been dealing with COVID-19. And as has been highlighted by other speakers, these perennial challenges are just one of the many competing priorities that government has to deal with in terms of both allocation of fiscal resources and even the manpower for health required to address these challenges. So the critical issues that we have in a global and interconnected world as we have it is that pathogens anywhere constitute a danger to everybody. And if you think about West Africa, for example, Lagos, Abuja is really just a 6 to 7 hour flight away from most European capitals. And from these European capitals, maybe another 6 to 8 hours away from at least the eastern seaboard of the United States. So it means that if you had a respiratory infection in a passenger on a flight at any one time, you can assume that spread has already occurred by the time you identify any of the cases. So this means that both from a global perspective, and indeed as we will find out later, from a national perspective, we will all be only as strong as our weakest link. So whether it's global health security or it's national health security. From the global perspective, there are legal frameworks as were alluded to under the international health regulations that sort of provide a framework, a benchmark against which countries need to prepare and respond to infectious diseases, and to also, of course, monitor and report them. As part of the provisions of the international health regulations, countries, including Nigeria, undertake voluntary assessments that are called joint external evaluations, which basically provide a means of assessing our readiness to respond to public health challenges. It comes up with an overall score called a Ready score. In 2017, Nigeria had a JEE that identified significant gaps in our health security. In response to this, the federal government of Nigeria developed a national action plan for health security, which, as expected and as required, is multi-sectoral. It takes a One Health approach to improving Nigeria's ability to respond to public health threats. And it was costed at what was conservatively at the time thought to be just under 200 billion naira. And of course, one thing that COVID has highlighted is that that budget really, which is not just for health, but for all of the sectors that are relevant and contribute to assuring our health security, was a conservative estimate. We then had a midterm JEE in 2019 that saw sort of a 7% improvement in our Ready score from 36% to 43%. And what this did was to, from 39% to 46%. What this underlined was the need for us to invest and pay a little bit more attention to subnational level health security strengthening, so as to ensure that we've got optimal, or as we journey towards our aspiration to have optimal epidemic preparedness and response. So, as I said in my meeting with our partners in the health security space, one of the NCDC's priority as part of the Federal Ministry of Health is to give some more attention to our subnational coordination, subnational support, and subnational strengthening activities in terms of epidemic preparedness and response. And there are various components to that. For example, to ensure improvements, we have committed to undertaking subnational JEEs. It's important to allow states to understand what their roles are and what gaps exist within their own space where they have control, in order to bring along the awareness, the understanding of how much power that they have in their space, and the need to, of course, mobilize the resources that are required to own their subnational preparedness and response activities. We have had subnational JEEs in Enugu, Kebbi, Kano, and in Lagos, and continue to expand this into many other states with the support, of course, of many partners, including, for example, the Lafia Project and Palladium. Alongside our work in the subnational JEEs is also the work that we're doing on subnational public health laws. I mean, a lot of this is supported through our collaboration with RT Research to Save Lives. Excuse me. And this is also an attempt to address some of the state level deficiencies in public health laws that we have seen that are required for states, for example, to be able to implement interventions in the public health space, especially in response to outbreaks and the like. As part of our efforts, so the attention that we give to decentralization or our subnational space, with every opportunity that we have had, for example, in National Economic Council meetings and other meetings with governors and health commissioners, my predecessor and now myself, have done our best and continue to work hard to ensure that states see the power that lies in their hands to change the health outcomes in their local governments or constituent local governments, and of course overall for the picture of those states. And this is one challenge that we have currently with cholera. You know, cholera, as has been highlighted earlier, we had the unenviable position of being the country that recorded the most cholera cases and deaths in 2021. And for a disease that really has a clear solution, the provision of safe water supply, it is really a bit of a disappointment to be have the top rank for that particular league table. But the federal government is not responsible for providing safe water supply in states. You know, there are water and sanitation, hygiene policies, enabling guidance, framework, investments, and all of that. But the bottom line, the issue that is key to cholera, for example, and indeed to many other water-associated diseases, is the provision of safe water supply. And we have tried, for example, to ensure that there's an understanding of the importance of this, and of course the ancillary or collateral benefits, because providing safe water supply doesn't just solve the problem with cholera, it solves the problem with many other diseases and many other health challenges. Issues around the economy, when people have more time, or the time that people take at the moment to go find safe water is then available to be committed to other gainful activities, especially in terms of the economy. It's important that our states realize the need to secure funding for health security in their own budgetary allocations. And we are pleased to see that through the activity of our partners like Nigeria Health Watch, like Listel and others, some states have already set the example by having budget lines for emergency preparedness, but it is vital that states fund their own epidemic preparedness and response, and that they demonstrate the political commitment and exemplary leadership that is required to steer and strengthen state-level health security as part of assuring our collective national health security. While we may all now have become used to associating the Nigeria Center for Disease Control and Prevention and the National Primary Healthcare and Development Agency with response to public health issues, especially as this is the face of response at the national level, it is not an accurate picture of what the reality is. There is only so much that can be done at national level. And I believe that there needs to be more ambition down to the lowest level, to primary healthcare facilities and in the communities that they serve. Beyond response, beyond sort of the emergency preparedness that we discussed for epidemic-prone diseases or notifiable diseases or other conditions that are considered priority, functional and accessible, easy to access primary healthcare facilities, or indeed universal healthcare coverage, is the first step in assuring our national health security. And this is why the recent primary healthcare summit and the attention that is being given to revitalizing our primary healthcare is very much welcome. I'm interested in that, working to provide access to care for people in communities, in my village, in your village, all across the country. But I also recognize as the one at the helm of Nigeria's National Primary Health Institution that this is also key for national health security. I'm thankful for organizations such as Nigeria Health Watch, which continue to advocate for increased funding and political commitments, and continue to bridge the gaps between the public and government. A lot has been said about bottom-up accountability and bottom planning. We also recognize the importance of the work that you and others do in actually holding everybody accountable, because accountability is key. Accountability to the people, accountability to funders, accountability to whether it's public funds or donor funds and all of that is essential to engender trust, both trust of partners and of course trust of the citizens that we serve. I'd also like to acknowledge the Drasa Health Trust and particularly appreciate the work that they do with students and healthcare workers in areas of antimicrobial resistance and the like. This, I mentioned this because, of course, antimicrobial resistance is another area of priority for the NCDC, and although a lot is not said about antimicrobial resistance, this is a really silent epidemic and challenge that is a public health threat in the country at subnational and national level, and that requires attention despite not making the headlines like monkeypox and COVID. In order to keep to time, I think I've spoken too long already. I'd like to end on this note. So, COVID-19 remains a headliner. I mean, yes, despite all the pandemic fatigue, both with citizens and healthcare workers, it still continues to be an important subject. It's an important subject because it's not just a problem for health. It's not just not a health challenge, but it's also been a challenge for lives and livelihoods. And we are still, in some respects, trying to recover to some of the economic damage that have resulted from this pandemic. But what is important is that all of the lessons learned from this pandemic response, and indeed all of the investments that have been made, we need to take those lessons forward. We need to consolidate those investments. We need to make sure that they continue to be fit for service. They continue to be accessible at the points where they are needed, and to contribute towards what will be the next phase of taking forward our lessons, which is to ensure decentralization of these resources as part of a decentralized health security, national health security plan. I thank you all for your time, and again, thanks to the organizers excuse me, for the opportunity to give this talk and to participate in this very important and topical meeting. Thank you very much.
Thank you so much, Dr. Ifedayo. Thank you for your very insightful contributions. And, thank you for what you said about ensuring that we have fit-for-service, accessible healthcare at all levels. That's why we're doing this. That's why we're here. And it's actually what we advocate for here at Nigeria Health Watch. So thank you so much, sir. And thank you for making our time to join us in spite of, some of the challenges that you have had. So now we have come to the, I would say it's the meat of the discussions that we're here to have, but we've already had so many insightful contributions from all of our speakers so far, even from the Goodwill Messages. So I'll just say we'll continue in that light. And I would like to invite the moderator of the first panel session, Dr. Ifeanyi Nsofo, who is the Senior New Voices Fellow at Aspen Institute, Washington, D.C., and will be moderating the first panel session.
Thank you, Kemi. Thank you for that beautiful whitewash. My name is Ifeanyi Nsofo, and it's really a pleasure to be part of this today. I want to thank Vivian and the team for putting this together. It is both sad and amusing when you hear Nigerians rant about the health sector on social media. So if I go to my village now and ask them, why is health not working in this community? They'll point to Buhari. And I think that that's a great disservice to the federal government of Nigeria, first of all, and also a disservice to our people, because our people still have not come to that realization that Nigeria is a federation. States have responsibilities. Local councils have responsibilities. And people must hold them accountable to do the right things. And I like what Nigeria Health has done over the years, trying to build an active citizenship for health, to get our people to be aware. A quarter of Nigerians stool in public. They stool in public. I like to use this example all the time because it just shows you how enormous the challenges are as far as infectious diseases are concerned. Dr. Adetayo Ifeda had already mentioned issues around, challenges in local councils, in the states, subnational levels, as well as all the lessons that we've learned from COVID-19 at the national level. And I think there has been a lot of success as far as COVID-19 infectious disease prevention and response are at the national level. But we want to see that happen at the state level. And I think that this particular event is also quite timely because we're about to enter the election season, or we're there already. And you don't see people asking what candidates for governorship elections or state house of assembly elections are doing. Everybody's asking who is going to be president. So we need to change that narrative. And to me, that is why I think that this first panel discussion is really very, very important. So that Nigerians begin to know that our health security depends on all the sectors, obviously, federal, state, local councils. But because health security may be global, but it happens local. So we need to get our people to begin to do the right things. We need to get our people to begin to hold elected representatives accountable for what they are supposed to do at the local, state, and federal levels. So I'm not going to waste much time speaking too much grammar. I will just move straight to the first panel discussion. And I'm going to call up the panelists for that particular one. Already Peter Hawkins, the UNICEF rep for Nigeria, had spoken. Peter, welcome. Please a round of applause for him. Dr. Morenike Alex Oko. She's the Director of Port Health Services, Federal Ministry of Health, and the National Team Lead, Operational and Administrative for Point of Entry in Nigeria. Welcome, Dr. Morenike. Dr. Yaya Disu. Dr. Yaya Disu Oyewoga is the Head of Communications at the Nigeria Center for Disease Control and Prevention. Dr. Olaolu Aderinola is the Head, Response Division, Department of Health Emergency Preparedness and Response at the NCDC. Dr. Festus Olukayode Shoyinka is the Director of Public Health, Ogun State Ministry of Health, and Incident Manager for COVID-19 in Ogun State. Okay, please, a round of applause for this panelist again. So before we start, and this is me talking to the panelists now, I think we need to be very strict with the time. Already we've lost about 20, 30 minutes with all the speeches that have gone before now. So please, I crave your indulgence, 1 minute only for each question so that we can have opportunities for the participants to ask questions and make comments. And I'm going to be very strict with time. So once you go above that, I'll gently call on you to. Okay, so the first question for me obviously has to go to the only lady on this panel because I'm a feminist. I have 2 children, they are both girls, so you understand why I'm positively disposed to women. So Dr. Alex Oko, Nigeria has 5 designated points of entry. At international airports, Abuja, Lagos, which saw about 70% of international travelers pass through in the last 1 year. What response measures were deployed at ports of entry in response to the COVID-19 pandemic?
Okay, thank you. Quickly, Nigeria actually has 4 designated points of entry, 3 airports, 3 international airports, and one seaport. And so post a lot of interventions and measures at points of entry were built on the lessons and experiences from the Ebola response in 2014. And so post-2014 saw the development of public health emergency contingency plans at major points of entry, starting with international airports, and also a national health emergency contingency plan, which coordinates all the plans for the various points of entry. And these plans provide a multi-sectoral, multi-stakeholder coordination mechanism through the public health emergency management teams at the points of entry. And this provides a platform for Port Health Services to mobilize all stakeholders at the points of entry. And so through this mechanism of the contingency plan, the response is coordinated at points of entry. And through that also you make the stakeholders aware and you sensitize them, and through that there's the development and review of standard operating procedures, trainings and simulations. So you also have national entry and exit screening measures which were adapted and implemented within the context of COVID-19 based on WHO guidelines. And these enhanced surveillance measures included the use of your, still in use actually, of the passenger self-reporting forms, but you have a digital version on the Nigeria International Portal. And then you have also the entry and exit screening, which involves primary and secondary screening of passengers, thermal detection, physical observation, and then to determine those who go into quarantine or into isolation. And then you have regular review of these screening protocols. So at some point also we had pre-departure and post-arrival COVID-19 PCR tests for passengers. And when you review those tests, you're able to determine who is a suspect case, who's actually, positive cases weren't expected to arrive, but we did have a few positive cases arriving. And then at some point, as the pandemic continued to evolve, these measures were reviewed. So we had closure of borders at some point, then thereafter we had the mask mandate, social distancing, and then now we're looking at COVID-19 vaccination cards of passengers. And to implement these measures, we needed to engage surge capacity personnel, talking about the human resources for health. But in a pandemic, you do know that your normal number of personnel will not be enough. So these measures provide the first line of defense within the surveillance architecture of the country and effectively links the points of entry to other parts of the national health surveillance system. So through the safer ports to SORMAS, to the state surveillance system, there's a well-articulated surveillance system there. And of course, you had the point of entry pillar at the presidential task force level. So in all of this, we agree the pandemic is not over. Yeah. The measures continue to be reviewed in line with the stage of the pandemic. Thank you. All right. I just want to crave your indulgence. The Director of Port Health Services couldn't be here. Okay. And so by some act of omission or commission, I'm here. I'm the Director of Public Health for the Federal Ministry of Health. Okay. Thank you.
All right. Thank you so much, Dr. Alice. I'm sorry about that error. Okay, Peter, I'm coming to you now because you're the foreigner here. And Nigerians are very hospitable people. So UNICEF really has been quite supportive to the government of Nigeria over the years, you know, as a multilateral partner. In your view, what lessons can be learned in terms of systems that need to be put in place to limit disruptions to essential health services like immunization as a result of, you know, the COVID-19 pandemic?
I think, as I said earlier on, I mean, I think the main thing is the human resources. And there, the issue there is ensuring that the capacity exists to be able to respond, not only to the situation in healthcare, services, across nutrition, maternal care, and immunization, but also to be able to respond to pandemics. If those human resources are not there, it's not predictive,
Okay, so let me just follow up a bit with you, Peter. So I want you to talk a bit about the roles of states, because I think, immunization should be one of the basic things we should be able to fund for our people. How can we get states to be much more responsible towards that?
Secondly, but I think your question is quite right. How is it done at state level? First of all, is to try and ensure that there's integrated routine immunization. What we're seeing both with polio, with COVID, and other things is that too many parallel programs that confuse the way that immunization is undertaken, whether it's static or outreach. So the concept of not losing anyone behind is not part and parcel of what it is. Zero-dose children is still very, very high, while immunization itself is continuing to go up. And I want to congratulate MPHCDA and SPCDA's, the mixed report which has just come out, shows that Nigeria has increased its immunization coverage to 56, 57%, which is laudable given in the meantime the pandemic has taken place. But each state needs to be accountable for integrated services, immunization program. Two, that the funding is done in a way that it ensures that it's about immunization, not about antigen. And that is, I think, the key going forward. And the experience from COVID demonstrates that. There has been an opportunity with vaccines from COVID on reinforcing the immunization system. The cold chain system's been tripled in size, it's reinforced. The immunization rates are going up, and the integration is part and parcel of that, but we need to take that a step further and ensure that financing is also integrated in that.
Okay. All right, thank you so much. So please, next time, Peter, could you move your mic a bit close to your mouth so that it's much more audible? Okay, so Dr. Disu, I'll come to you. By the way, very few people here know that Dr. Disu was part of the African Union volunteers, for the Ebola, to stem the Ebola outbreak across West Africa. So please a round of applause for him, because he's really one of the heroes that, stemmed that particular pandemic. So COVID-19 pandemic has highlighted the role of effective and inclusive risk communications as an important component of disease outbreak response. Can you share insights on the development and deployment of the NCDC hashtag Take Responsibility campaign? It was quite popular, in 2020 and 2021.
Thank you very much. In the beginning, we all understood that the novelty of the COVID-19 disease itself caused widespread apprehension as well as panic among the population, not just within Nigeria and outside Nigeria. And this was due to the fact that the uncertainty surrounding the cause of the disease, its mode of transmission, as well as treatment. So it was difficult to predict. In fact, there were circumstances that I can describe as VUCA circumstances: volatility, uncertainty, complexity, and ambiguity, which made it very difficult for us to cope the rate at which things evolved. And as well as it was difficult to predict because of uncertainty and to analyze because of complexity. A lot of things are happening at different levels at the same time across the globe. And then ambiguity, difficult to interpret each action, whether by experts or by international perspective or local perspectives. So against the backdrop of the lockdown and the limited socioeconomic situation, we realized that initial measures that we deployed were not working. Messaging, IEC materials we put out, and the leadership then just called the communication team that we need to do something. We cannot use our routine operations, our normal technical know-how, to address this. I remember Dr. Olaolu was the incident manager then. I sent in like 2 proposals for intervening at the state level, and the then DG had to send them back that you need to be creative. He had been in China, so he understood the situation. So because of this, we realized that we have to be adaptive in our approach, and we have to think outside the box. And we needed a campaign that will have a theme that will resonate with everybody, that will be a strategic principle that will distill expectations across sectors, across level, individual level, family level, and so on. That was where we gave back to take responsibility that we launched through the media. And with time, it became the household language at every level. And what made it work? And there was good preparedness. We did not know, around November, we trained about 20 spokespersons. The NCDC did. It was for about 3 months. It started around June. And then there was this training of master trainer on risk communication that WHO supported. They came from Afro. It was in December. It was done in Lagos. And we had the existing National Risk Control Technical Working Group that's made up of stakeholders from different sectors and partners. And they were trained in Lagos in that December 2019. And we're planning to cascade this to the state before the COVID-19 came. And then we also set up a crisis communication team. And we had our protocols. And then we had a multi-hazard risk communication guideline in development as required by JEE. So those tools were already there. So it was easy for us to just adapt, to quickly assemble our multi-hazard risk communication technical working group to develop a risk communication and community engagement COVID-19 containment strategy to guide everyone. And then crisis communication was activated, headed by the DG of the organization, to answer the questions and concerns of the people. The one good thing that DJE did for us was the rumor management team. We were leveraging on the event-based surveillance system of NCDC before COVID-19 came. So when COVID-19 came, they were able to monitor misinformation, disinformation, and to quickly respond. Then activation of EOC risk communication pillar, and who was intervening with other response.
Okay, Dr. Disu, I mean, I think you've got this. You got this covered. I'm sure you have more opportunities to
thank you very much.
To respond to this. But I take away 2 things from what you've said. The fact that you guys were prepared. So it's not a question of it happened and people started scrambling. There were some structures already in place. And for me, I think this reminds me of this particular quote from the University of Global Health Equity in Rwanda, that for us to achieve equity in healthcare, we must achieve equity in health education. People need to know, and this information disseminated in ways that it's easy for people to really chew and understand. But thank you so much, Dr. Disu. I'm sure you will have time to revisit again. So, Dr. Soyinka, it's almost like, is everybody from, Ogun State named Soyinka? By the way, Professor Soyinka's birthday was yesterday or 2 days ago. So please extend our greetings to him. But Ogun State is quite strategic. It has borders. It has an international border with Benin Republic. It borders 4 other states, Lagos, Oyo, Osun, and Ondo states. How was your response in the state structured, to take into consideration this peculiar location of the state, migration and social issues regarding the COVID-19 pandemic?
Thank you very much. In addition to those things that you have mentioned, some other peculiarities about Ogun State is the fact that we have a large number of industries that are also harboring people from the Republic of China. It's a major hub for industries and a major route for transport of goods from Lagos to other parts of the country and through the West African sub-region. So on the 27th of February, when the first case happened, it actually took us by surprise because we had thought that this was a disease attached to international travels. So we had thought that Lagos was going to be the first place, or maybe Abuja. Then we have enough time to prepare. However, we were both in
preparedness mode and response mode at the same time, because when it happens, we quickly summoned a meeting, and then for the Commissioner for Health to assess the situation, and then immediately went on air. Then the governor also went on air. Very good enough for us. NCDC sent a team of experts to the state, and we quickly activated our incident management system, and then formed a multi-sectoral, multidisciplinary EOC, which was activated. Now, at the state level, the state government level, the task force was led by the deputy governor, and at the health sector level, the EOC was, the incident manager was my humble self, and the Honorable Commissioner for Health was the chairman of the coordination team, and we co-chaired that. And that EOC also tactically mobilized all the various key persons in the MDAs in the health sector, the Primary Health Care Board, the Hospitals Management Board, the tertiary facilities, then the local government level, we mobilized the rapid response team, and all along. At the level of the LGA, we have a 5-man rapid response team, the DSNOs, then we also had in each of the facility an IPC focal person, and also in key facilities, the very big ones, we had case managers, so who could also respond to issues from the center. So the whole response was being coordinated at the EOC level, but we were in touch with all these facilities. At tertiary institution, there were also EOC created at Olabisi Onabanjo University Teaching Hospital, Federal Medical Center, where a lot of our cases were initially picked from. Also, they were being mobilized. And so this was the structure we used to deploy the response. However, at the initial stage, many things were done at the state level until, because our first 7 weeks, all our cases that were dictated were imported. But subsequently, we had to carry out a community-based screening on our own in the 20 LGAs, and we discovered that already we have cases that were not epidemiologically linked to the ones that we had before, and then we quickly had to change our strategy to decentralize the response, to make sure that funds were passed across to the rapid response team at the LGA level for them to also be able to do a lot of, what do I call it now, response on at their own level. Now, with regards to the international cases and then our borders, which you have raised, we had an established linkage with Lagos for us to receive list of persons of interest whose destination is Ogun State. And also we had linkages with other states, adjoining states with us, for us to also pass similar thing to them for people who are coming into the state or into the country through the Benin Republic border. And that was a big eye-opener to us also. When the lockdown occurred, we discovered that there were some other unmanned land crosses, apart from the ones that we are routinely monitoring. So we had to develop strategy to ensure that those other places too were manned. However, at the initial stage...
Okay, sorry, Doctor. Okay, can you just round up your thought here?
Yes, at the initial stage, the surveillance at those levels was challenged by the fact that health facilities were not close to that place. We were making use of Port Health staff with support of the WHO and our system. And so we needed to, at that time we were still using PCR before the advent of the rapid test kit, to collect samples, and before the result comes, we were challenged by the fact that there was no place to keep those persons. Hotels around Benin Republic, you couldn't keep them outside from coming in while you're waiting for results. Because of the nature of what they have heard about the pandemic, they could not accept them. There was a time that we took the risk of just carrying a large number of persons, about 127, from the border and just took them to Osogbo because there was no place for us to keep them. Unfortunately enough, about 18 of them tested positive. So, but that has made us realize some gaps that we needed to bridge with regards to our border in that response.
But so Osogbo is in Osun, right?
Osun.
So obviously you went to another state in order to do that. Okay. Thank you so much, Dr. Soyinka. Dr. Olaolu, so to me, I think one of the major success as far as Nigeria's COVID-19 response is concerned is the coordination by the Presidential Task Force on COVID-19. I thought that was unprecedented. They gave us daily briefings, and obviously NCDC was a core part of that. What do you think worked and what didn't work as far as, just give us maybe two of each as far as that task force is concerned?
Okay, thank you for having me. So looking at what worked, the thing is this: any public health event requires the whole of society to be on one page, and the society needs leadership. And that's what the Presidential Task Force gave. NCDC alone couldn't have done it because it was multi-sectoral. You needed several ministries to be on board, several agencies, which NCDC wouldn't have been able to shoulder itself. So that brought a lot of coordination, a lot of resource mobilization, resources that NCDC wouldn't have been able to mobilize alone. The Presidential Task Force was able to do that. And one thing was that we also had one voice. There wasn't any dissenting message from any of the ministries and agencies. So that brought that unity of purpose together. Resource mobilization was very important. Partnerships, bringing the private sector together under one umbrella. During the introduction to the private sector was like, how do we really engage? With the Presidential Task Force on board, those issues we were able to do that and bring the private sector on board. They manage the resources themselves, and I think those were the good things that really worked with the Presidential Task Force.
Okay, what if you were to assemble another Presidential Task Force for the next pandemic? And I'm sure the average Nigerian will say, no, it's not our portion. We won't have another pandemic, but it will happen. It is coming. What one thing will you do differently as far as that task force is concerned?
So I guess one of the things that I saw occurred was the Presidential Task Force was supposed to just be strategic. At a point in time, they had to be operational.
Okay.
So at times there was an overlap in what the operational team should do and what the strategic team should do. So I think presently there's a bill on public health so that those roles and responsibilities will be well delineated.
Okay. Okay, still on you, Dr. Olaolu. So if you look at the response at the subnational level, because I mean some of the things you hear, or rather that I even heard before COVID was there's an outbreak of cholera in a state, they wait for NCDC to come, NCDC gets there, they're even asking, didn't you come with IV giving set, drips and, very ridiculous things people, that we hear. What were some of the challenges that you observed as NCDC as far as the subnational response was concerned during COVID?
Okay, so at the subnational level, what really guides our surveillance is the integrated disease surveillance and response.
Okay.
And there are responsibilities. Each state is supposed to have its own Public Health Emergency Response Committee, which used to be the Epidemic Preparedness and Response Committee at the state level and also at the local government level. But I think the key things has been, one, there is inadequate human resource to be able to manage that. You find in some states there are incident managers for life, the incident manager for cholera, incident manager for all the diseases, no rest, so it doesn't really give them time to be able to do that. So not having enough human resource and skilled human resource to be able to respond to those public health events. The other thing is also not having the resources to work with, finances at times, to even respond to a public health event. There's no fuel in the vehicle. They have to go with their own personal cars, which shows the passion that is really within the health workforce at the state level, but they need to have the tools to be able to respond appropriately. And NCDC, we've noted that, and we've also supported the states ensuring that trainings are done on rapid response team, having PHEOCs to be put in place to support them. And we also help mobilize resources, looking at the Redise Fund. We got 100 million for each of the states to be able to respond, and which the states are accounted for.
Okay. All right. Thank you so much, Olaolu. Dr. Alex, I'm coming back to you. So a number of states in Nigeria have international borders. Years back when I worked with the National Program on Immunization, I think that was the first time I went to one of those borders in Borondo State, Gamborungala. We could stroll in the evening to go and eat bushmeat across in Cameroon and walk back again. So when people hear international borders, they think there is one particular place where everybody goes through. And I can imagine it's very challenging for Port Health to coordinate. So how have you been able to manage that as far as states that have international borders are concerned to make your work much more efficient?
Have porous borders, and obviously you cannot man porous borders. And if you're talking about Borno State, then you're looking at issues of security. You're looking at issues around security. So those borders cannot be manned. So at some point, at some of those borders, we had what you call joint patrol teams involving Port Health, immigration, and the other security agencies. And so because of the multi-stakeholder ecosystem, we were able to train them to recognize the signs and symptoms of some of those infectious diseases, and then set up protocols as to what they could do. But the reality is that you cannot man porous borders. So right now, we're looking at the communities around the borders, and also cross-border collaboration with neighboring countries. And Nigeria just hosted a cross-border collaboration meeting sponsored by WAHO to strengthen that, again in line with the evolving the pandemic and scaling up on measures for preparedness and prevention. The reality is that at the subnational level, these points of entries are located within states, and the outbreaks occur within those communities. So, and just like Ogun State said, a lot of those cases are imported. So sensitizing the communities to be able to report through the DSNOs and the state health system is very important. And so you find that at the subnational level also, the personnel have to be properly trained, but that is lacking in many cases. And so you want those measures at the state level to link up with the federal level. So it's a whole gamut of things, but for the porous borders, it's a very difficult situation.
Okay, so Peter, I'm back. So UNICEF is part of the, we call these village people in Nigeria when they want to embarrass you. So the UNICEF is part of the one UN COVID-19 basket fund. How effective was that in mobilizing funds, especially within the subnational levels, and ensuring accountability, even while that was being done? Do you have village people?
I have many villages in Nigeria.
Okay.
All
right, that's great.
Many years. Also, it's important to say that the UN fund
this was very difficult to do that more successfully than perhaps most other areas did. I think trying to get state-level accountability was slightly more difficult for many of the agencies. For us, it was much easier because offices and we've got our agreements with the state governors, and it was much easier than ability. But I think, as I said earlier, we do really need to look at how states are funded, because and accountability have to come hand in hand. The plan has to be much clearer and much more robust with costed budgets so that accountability can easily be alluded to. And I think MOU is now for the state. Accountability and the resources, decentralized resources, is going forward to have a step change in the way that is done. Of that, it's good. Thank you.
Okay. Okay, Dr. Shoyinka, I'm back. Similar question to what I asked Dr. Alex. Really, what are some of the just give us 2 lessons you've learned in managing an outbreak within a state that has an international border?
Thank you very much. One of the things that became an eye-opener to us with regards to COVID-19 and our borders is the fact that the issue of port health services at that level need to be strengthened. Then when you have people to quarantine, there are no facilities at the border to achieve that. The next closest facility to respond to COVID-19 at that point that we provided was about almost 140 kilometers away. But one of the things we have done now, with support of partners, we have been able to put an 80-bedded isolation facility in Ota, which is the closest we could get. And also, we tried to prepare General Hospital in Jiroko to have a 10-bedded facility for us, 5 for male, 5 for female, but that is still also a little bit far from that place. That's one. Number 2 is the fact that Ogun State was left on our own to look after the responsibility of those persons crossing international border without much support from the federal, which we felt shouldn't have been so for a pandemic like COVID-19, more so when there were issues of maybe state government looking up to federal and looking up to partners. One of the challenges we have always had is that it's not as if plans are not put in place. Plans are put in place, but the system to get the funding to do what you need to do is slow, and it's like we're waiting for the next person to, there's over-dependence on partners. And so they wait as if, they will soon come, they will soon come. And that's the challenge that we've had. And the surveillance system with our testing initially with PCR was challenged. But when the RDT came, we had to deploy that much to the border system down. Then the issue of conveyance of persons of interest who probably you might not find a place to quarantine to their place of destination was another challenge that we had. Like I told you of the cases that we have to move across state. So we put down the vehicle, follow them up to the border of Oshogbo where they were going and handing them over to the government officials there. So those were the challenges that I think should be mitigated against for response, in subsequent times.
Okay, thank you so much, Dr. Shoyinka. I mean, even Ota is about 40 kilometers from Idiroko.
With the state of the road also.
Yeah.
Also include, yes.
Yeah. So
that's why we're looking at a 10-bedded unit
You did roll call. Okay. Okay, thank you so much, Dr. Inka. Dr. Disu, so there's no doubt that, the hashtag Take Responsibility campaign was successful. What was your experience, implementing that within the subnational level? I mean, and what two lessons can you take away for future pandemics or other infectious disease outbreaks?
Okay, let me quickly start from the two lessons. I think inclusiveness in terms of stakeholders' engagement to make sure that everybody is on board for optimization of resources as well as consistent messaging. Then, in terms of audience, leave nobody out to make sure that the audience are considered, their needs are considered in planning your messaging. Example, when we started the campaign, the response, somebody came from Association of Sign Language Interpreters of Nigeria. To us, they wanted materials to go and use for the deaf. And I said, come and join our meeting. When he came with whether the secretary or the chairman of the Deaf Association. And so they were now interpreting what we were saying. First thing the man said was, the jingles we have been bringing out, we did not consider the deaf. And they gave us the statistics. So since then, they joined our meeting. We also linked them with PTF, the sign language interpreters are interpreting. So we now made our jingles video audio friendly. And then we now understand why we need to include everybody, persons with special needs. We still have a long way to go. And now we're working with National Commission for Persons with Disability to chart a roadmap for their inclusion in national health security. Okay. So that is on the table. And then use of data-driven, science-based, and context-specific messaging and strategy, communication strategy, was very helpful. We're able to track our progress. We're able to gauge the mood of the nation, the emotions, the knowledge gaps, and able to respond accordingly. So our weekly messaging was we're able to adapt to what the needs were. And then journalists, involving the journalists, training them on how to translate understandable technical information into understandable narratives to the public. And then, so that is still ongoing. We're trying to launch a course. For the subnational, now coordination still remains a challenge at subnational level, and we're trying to build their capacity. We're trying to work with stakeholders to expand the existing social mobilization committee that have been oriented on immunization to include stakeholders that can help them respond to emergencies, like Red Cross, like if they have SEMA, equivalent of NEMA at the national level, and so on. Okay. And then, again, build their capacity of messaging, as in use of data to guide messaging. We have set up, through the support of Global Fund, a rumor management system in 12 states. And we want to still do more. And now we now have not just monitoring misinformation or doing info surveillance online. They now include stakeholders at the community level. I think Ogun State is one of the states that have been trained for that. So that we have integrated rumor management strategy. Okay. So inclusiveness, adaptiveness, and use of data to guide what we do is very key.
Awesome. Thank you so much. I think we probably have 5 to 10 minutes, questions, comments from the audience. And again, I'm also going to be quite strict, 30 seconds. So let's just see the hands. Okay, can somebody?
Sorry, but could we maybe do Q&A after the second panel session here, since we're kind of short for time?
Okay.
Please just take note of your questions, and then they'll be taken immediately after the second panel session.
All right, thank you so much, Kemi. So I guess at this point in time, maybe just, one last thing you want to say, 30 seconds. Let's start from Peter and just run down. One last thing as far as, lessons from COVID and subnational levels.
The capacity is in place, but you need to finance that capacity with accountability.
Okay. So to me as an Igbo man, that makes sense. It's money, ultimately. Okay, Alex?
So just to say that the health threats. So strong subnational systems that are interconnected are the building blocks for an effective national architecture for health emergency preparedness and response. And it's important that the coordination structures at the subnational level are just as robust as at the national level to ensure that we strengthen health security.
Awesome, thank you. Dr. Diso.
Be proactive rather than reactive, and engagement in peacetime is very necessary for synergy during the emergencies. And again, I would also like to let us know that we should prioritize communication, because most times that's the last we consider on the table, because it's the glue that binds everything together.
Absolutely.
We are not yet where we are going, but we are miles away from where we started.
Awesome, thank you.
Okay, so my message is about preparation. You need to really prepare well at the subnational level to have a good response. They need collaboration with the academia, with research institutions. We have so many teaching hospitals, so many schools of public health that should be supporting the state in investigations, so that we build the capacity at the state level, and there is collaboration between those institutions. We have a lot of resident doctors and all that should really be part of what the state is doing, and that will beef up the human resource for health. And we also need the states to really have the budget line for their public health emergency operations centers.
Okay.
Thank you.
Thank you so much, Dr. Shoyinka.
Thank you very much. One of the things that we discovered is that when you have such kind of an emergency that overwhelms your existing human resource for health, you want to see that the right thing to do is to mobilize, from elsewhere. And you talk about volunteers. But we have discovered that in Nigeria, there's nothing like volunteerism. People will not do anything for nothing. Because we saw the way Lagos addressed their issue, and some people even from Ogun State also went to help in the response in Lagos State. That was because they had the fund to give these volunteers, so to say. And even though we have a lot of institutions that could have come to our aid, but in the same way that I have said, that unless initially a lot of these response were from staff of the Ministry of Health, until it became obvious that we needed to call for more help. So there's a need for us to have that. And I want to say lastly that I'm happy that recently I heard that the NCDC will also be looked after from the Basic Healthcare Provision Fund. And if we could use the same structure by which the other gateways are being run to have the development of that to state level, that could provide some ready-made fund for such emergency response. Thank you.
Okay, thank you so much. Is it not ironic? We started from money and ended with money. Thank you so much. Kemi, over to you.
Thank you so much, Dr. Ifeanyi. Please don't rush off. Let's take a quick picture with the speakers. And Vivian, if you will, please join them for a quick picture. Thank you so much to our esteemed speakers. Thank you for sharing your insights. It was really interesting to hear. And one thing I heard consistently across all of the speakers was the need for a whole of society and whole of government approach. And I think that was strongly demonstrated across all levels. Multi-sectoral collaboration was key, and it worked. Please just stand up and stand right in front there. Vivian will join you for a picture. Thank you so very much. So we're going to go very quickly to the second panel session, which is going to be moderated by my humble self here. So I would like to introduce my esteemed speakers. This is one session that a lot has been said about already during this policy dialogue, and it's because of how important the private sector response to the COVID-19 pandemic was. Sorry. And just like we saw, we all know that Nigeria is, the Nigerian market is very heavily tilted towards the informal sector. Informal sector contributes, to some 65% of Nigeria's economic output. And just like we saw during the COVID-19 pandemic, there was an unprecedented hit to this informal sector due to restrictions in movements and lockdowns. And this, I'm sure, is one of the things that prompted the response that the private sector then mounted to the COVID-19 pandemic. And we saw coalitions such as COVID come up, and PSHAN as well, the Private Sector Health Alliance for Nigeria. And COVID, for example, contributed more than 26 billion naira to the COVID-19 response. And it had key stakeholders such as Dangote Foundation, the Central Bank of Nigeria, of course, and then we had Access Bank in there. And it was really impactful what this coalition did. They rapidly mounted isolation facilities across Nigeria. They also supported laboratory strengthening. And that was just what was visible, across larger platforms and larger coalitions. There were also small pockets of support mounted by the private sector, even at the subnational level. And we saw a lot of that happen, such as in Lagos State. And a very clear example is how Lagos State leveraged the private sector strongly to strengthen laboratory systems and treatment facilities really rapidly when the COVID-19 pandemic hit. So I'm not going to belabor this point too much. We all lived the experience. We know how strong the private sector response was to the COVID-19 pandemic. And we also know how, due to the hit to the informal sector and the economic outputs of Nigeria, there was a need to then provide economic relief as well, which the private sector was really instrumental in providing. So that brings me to the session that we're going to discuss, which is on the role of the private sector. And basically we'll be discussing how the capacity of the private sector can be leveraged and harnessed to strengthen health security at the subnational level. And I have an incredible lineup of speakers for this. I'd like to start by introducing Mrs. Niniola Williams, who is the Managing Director at Drasa Health Trust. Please put your hands together for her. Please have your seats. Drasa Health Trust currently supports infection prevention and control and antimicrobial resistance capacity, both at national and subnational levels, and they do really great work. Your hands together for her again. She's one of my favorites, so I really don't mind giving her 3 rounds of applause. The next is Dr. Anne Ada-Ogo. Their speaker profiles are actually in your program, so if you want to know more about them, please just flip, and you would see everything that you need to know about them there. So Dr. Anne Ada-Ogo is Head of Policy at the Private Sector Health Alliance of Nigeria, PSHAN for short, and she'll be speaking to how the private sector is really strengthening health system structures, both at national and subnational level. They're currently running a campaign to strengthen primary healthcare centers across Nigeria. It will be really interesting to hear about how that works. Next is Mr. Aliu Israel, who is National Laboratory Manager at Cleaner Lancet Laboratories. I already spoke about how laboratories were strengthened by the private sector during the COVID-19 response. He'll be giving us more insights on that. And then I have Dr. Omokudu Idogo, who is the Managing Director at Society for Family Health. Society for Family Health is an indigenous organization that does a lot of work strengthening health systems at national and subnational level. And finally, I have Dr. Emmanuel Agogo, who is Country Director at Resolve to Save Lives. Resolve to Save Lives is one of the partners of the Nigeria Center for Disease Control, and they provide a lot of technical and financial support to health security strengthening at national and subnational level. Thank you so much. Okay, we're going to get right into it. And I would like to start with you, actually, Dr. Emmanuel. So at the beginning of the pandemic, given how, well, the truth is, these things are usually not so sudden. But given that we are Nigeria, it was sudden. And very quickly, Resolve to Save Lives was able to mobilize a revolving fund for Nigeria Center for Disease Control to respond to the pandemic and to mobilize resources and mobilize manpower very quickly to stem the spread of the pandemic. Could you tell us about this fund and how well you think it worked, and going forward, how replicable you think funding mechanisms like that can be in preparing for future pandemics, also at the subnational level?
Yeah, thank you for that question. So I'll take a cue from what Disu said, that actually, when you think about preparedness, the situation in Nigeria was that because of the the DG as well talked about it, because of the JE that happened in 2017 and the repeat in 2019, it was not a situation of where there was nothing. And I think a lot of work, we wouldn't go into the amount of work that was done previously to respond to all the outbreaks that had happened previously, which included not just the Ebola that happened in 2013, but also the series of outbreaks of monkeypox, meningitis, Lassa fever, that the NCDC, as well as other partners, including the NPH, CDA, and other international support, has really contributed to ensuring that systems were in place. So I would say that the Rapid Response Fund, which Resolve to Save Lives set up in collaboration with the NCDC and with fiscal management by the AFINET, was one of many mechanisms of trying to address the gaps in enabling factors that make preparedness and response possible. So the Rapid Response Fund was just a funding mechanism where, when you had an outbreak, there was money available to send teams to the field. We had done some analysis previously where we looked at outbreaks that had happened in the past, and the bottlenecks for actually responding, where there was a gap from between 1 day to 30 days of sending teams to the field, was actually having funding to send people out. And I think one of the key things that the Rapid Response Fund did was to provide flexible funding available to the DG of NCDC, with triggering from the EOC when there was an outbreak to send people to the field. Just to conclude, so we can move on, is the fact that there were other mechanisms in place, including looking at other ways of raising funding at the national level, including looking at increasing budgetary allocation to NCDC and looking at specific budget lines that were flexible enough for this purpose. We know how government does budgeting. If you do not have funding for an activity, if you spend it, it's variance, and you can get into a lot of trouble for it. So really beginning to think about these needs ahead and setting up this system. So the Rapid Response Funds was leveraged by NCDC at the very early stage to send teams to the field before the bigger fundings were available from government and from partners.
Thank you for that summary. But was it effective though, and how sustainable is a fund like this, particularly seeing as we're looking at the subnational level? Is this something that states could maybe look into deploying?
So it is. I think it's a very sustainable model. So we, because the framework was in place, actually COVID and Dangote Foundation put some funding in that mechanism because they could. The problem with a lot of this funding is that people don't trust what happens to it. But because we had SOPs in place, a fiscal system in place, you could have a report that said this person was paid X amount to go to the field for this number of days, and you could track it. So that system was leveraged by COVID, it was leveraged by Dangote Foundation, and used to support teams down the line in outbreaks. And we're beginning to work with NCDC as a process of really doing, as we've done the national JEs, to do state JEs and identify these gaps at the state level and set up similar mechanisms managed from the EOC level where funding is available for teams to go out. Because outbreaks, much as we talk about them globally, are local. You start with a small community, and if you're not able to send that epidemiologist or that healthcare worker or provide the resources to stem it, then it becomes an epidemic instead of a small outbreak, a small fire that you can put out. So the Rapid Response Fund is actually a mechanism to put out small fires before a huge bonfire or a big conflagration happens.
Great, thank you. I mean, you touched on accountability, which is one thing that has been said repeatedly here, and that fund had strong accountability mechanisms, which, you know, is definitely a model that should be replicated going forward. So I'll come to you, Mrs. Niniola Williams. You currently support key technical areas of the international health regulations, both at national and subnational levels, including infection prevention and control, antimicrobial resistance, and points of entry. What key role do you think the private sector can play, you know, in supporting and bridging some of these gaps in technical areas at the subnational level as well?
Yeah, so I think I can use our experience as an example. As when I speak about private sector, I'm not just speaking about private companies and foundations, but also nonprofits, civil society, academia, who also have, you know, a very big role to play. And the way I see it is that our role is really to take what's happening at the federal level and domesticate it. We're here to talk about decentralizing, and I think that's really where the private sector can lend its strength. And I'll give a couple of examples. When it comes to health security, Dr. Alex Oko spoke about a lot of the work we've been doing in partnership with ProHealth International. I'll give an example from December 2019. We had 4 designated points of entry in Nigeria, according to WHO. And every designated point of entry must have a public health emergency contingency plan. And there was one of the 4 that didn't. That was Apapa Seaport in Lagos. And so we worked with ProHealth to develop the first contingency plan. And that came, of course, just months before the first case of COVID-19. And that's an example of private sector coming in to fill a gap, which is driven by, you know, a national or a federal, in this case, international regulation that we needed to comply with. And since then, we've expanded to 13 other points of entry in 10 states, and we're replicating the same process, building their capacity to detect, respond to. I think Peter said earlier that it's not just about surveillance. Okay, you know that someone is coming in on this plane or on this vessel at the seaport, and this person is, you know, possibly infected. But then what do? How do you connect with the states? Because at the end of the day, that person needs to be evacuated. Who's bringing the ambulance? What are all the structures and the details? And so these plans helped us create coordination, communication, reporting, and response mechanisms, and build the capacity of the human resource at these points of entry. And since then, we've also expanded to work at the border communities. So looking at 6 land borders where we're working in the north, looking at the people who live and work around those places, because they are really so important. They know who is local and who is not. If you train them on the signs and symptoms to look out for, you train them on how to report these things, they can be a very effective part of our national health security system. And so I think that those are just some of the things that we've been doing in health security. But I want to talk a little bit about AMR. Dr. Aditfa mentioned our AMR project as well. We've been in schools around the country since 2018, and we've developed an AMR project that is in collaboration with WHO. And what we're doing is training youth on how to become ambassadors for AMR. And these youth were very useful during COVID-19 because apart from their AMR knowledge, they also understand general hygiene, how to wash your hands properly, how to keep your environment clean. So a lot of the things we were trying to get into the communities at that point, these youth already knew how to do. And as ambassadors, they can influence people in their homes, in their schools, in their communities on how to also do those things. And so I think it's another example of how to domesticate something that needs to be done at that needs to be implemented from the federal level at the subnational level. And finally, when it comes to IPC, our expertise in IPC has been something we've been doing since 2017. We do short courses, we do a full 1-year diploma course through our partnership with the University of Lagos as well. And so during COVID-19, in January 2020, we went to the Lagos state government and we said, we need to do something. What are you guys doing? They said, okay, we've activated our EOC. So we joined the EOC and we said, here's what we're bringing to the table. We are going to do an assessment of Mainland Hospital Yaba, that's the infectious disease hospital. And we're going to train all the frontline health workers because we know that this thing is likely going to come. And of course, it eventually did. And they were prepared. We had given them all they needed to know about COVID, how it spreads and all of that. And so I think these are examples of how the private sector can contribute to domesticating and helping subnational states and other subnational entities to adopt, adapt, and really customize what needs to be done to improve our health security as a nation.
Thank you so much, Nino. Those were very insightful. And I particularly, I like some of the points you made about strengthening structures at the subnational level and how some of the mechanisms and the coordination mechanisms that you built across points of entry actually then, involved all the players, all key players, even up to the community level. That's really great work right there, and definitely something that we could learn for, building better after COVID. So I'll come to you, Mr. Aliu Israel. So the private sector was very key in rapidly mobilizing, screening and testing capacities for COVID-19, for the COVID-19 pandemic. So what key capacities were built during the COVID-19 pandemic, and how can these gains be sustained after the pandemic and for strengthening health security?
Okay, thank you for the question. It is no doubt that over the period of this COVID response, that capacity has been built in the private laboratory sector. To count some of them include one, the technical expertise has gone. Before the COVID response, we know the deficiency when it comes to the knowledge in molecular science, in terms of the technical expertise. As a quality system expert, we know that one of the key quality system essential is personnel, because every organization is being driven by quality personnel, by people who understand the system and people who are able to drive the system. So for the private sector to be able to contribute so much, it shows that the technical expertise through trainings and others has actually increased. Apart from the technical expertise, we also note that the quality of laboratory results has greatly improved, because even at the onset of the COVID test, we had incidences where some of our lab results were rejected at some international airlines and the rest. And it caused for a great response, and this we'll begin to look at. And three things that actually indicate the quality of the result is one, the accuracy of the result, the reliability of the result, and the timeliness of the result. And this we're able to achieve in terms of the turnaround time, where someone can come in 24 hours and you get your result. Unlike the normal conventional laboratory practice where people take 1 week to run even the common hormonal assays. So with this response, they say that they now understand that the customers or the client or the patient, as you may call it, is key. And the focus was majorly on them. Apart from that, there have also been increase in terms of technology and of platform optimization. Before COVID, we could count how many labs in Nigeria that has some sophisticated equipment like molecular testing and the rest, PCR, even the common biosafety cabinet, we could count how many. But now, almost all those facilities has that. And as a result of that, even the technology application, now you could be at your home, order a test, you get someone come to your place, collect the sample, you get, through your app, you get your result. Even the interpretation of the result, graphical representation, you don't even need a doctor to interpret your result. With the graphical representation alone, you can be able to say, this result is normal, this is abnormal. These are some of the things that will actually come in play. Also that, apart from other technical experts that are also in terms of infrastructural development, a lot of organizations, especially the laboratory sectors and private, have actually developed their facilities, built new ones, some of them upgraded from the existing ones that is currently there. Why? Because of the response. And it is obvious because at every organization, as the private sector, we are more business-minded than the public sector. That is sure, because one, we want to actually meet the customer's need. And first is to identify the customer's need, meet the customer's need and exceed it. And that is the only way you can continuously be in business. So if you are not meeting the customer's need or the patient, whatever you call them, you are not exceeding their needs, you can be out of business, and the competition is strong out there. So that has kept the focus from them. When we talk about what are the things that can sustain this capacity that we have built or that has been built over the period of time, one is process improvement. Now, because any process that is not improved over a period of time becomes stale, and that is the largest when it comes to quality. At every capacity where you are, there's always a place of improvement, and process improvement program has been key, and it is key to sustain some of this capacity that has been built. Apart from process improvement, we also have accreditations, regulatory agency, because this accreditation and regulatory agency helps to keep in check. Because normally people don't want to do what is expected, but they will always want to do what is inspected. So if you go ahead to keep inspecting them, keep keeping them in check, definitely they don't want to, because accreditation is not a It's not a one-time thing. It's something that you do, you keep having, you keep increasing. Because if you don't keep that quality standard, definitely over a period of time, your accreditation can also be withdrawn. So regulation, accreditation is one way to also help to do. Apart from that, I know my time is running. We also have private and public partnership. That is key. Because without that, you won't be able to do much. Even when the ideas are there, you need partners. And not just partners, also the ability for the private sector to also attract investors. There are a lot of some practice for some private organizations that will not allow you to attract investors because they are against international practice. And when some of these partners comes, they won't tell you. They go through those checklists, and once you are not meeting them, definitely you won't attract that interest. And also investors, because it is becoming, the healthcare is becoming a business world, which is so a lot of our investors that take money outside, they can invest it in the private sector, collaborate with. And even like 3 days ago, we also had another collaboration from Health Holding, collaborating with Cebalance South Africa, and to ensure that healthcare are also increased. So these are many more that can be used to sustain what we're currently doing. Thank you
So much. At the risk of taking a bit more time, I do have a follow-up question on that just before we move on to other broader ways that private-public partnerships can be strengthened. And it's, it takes off on your second to last point. You talked about accreditation and regulation, and we know how key government was in ensuring that COVID-19 testing was accredited and regulated, both at national and subnational levels. So could you speak, just maybe in a minute, speak more to how those kinds of public-private partnerships and synergies can be strengthened as we look to sustaining the gains that were achieved during the pandemic?
One, first and foremost, for them to be sustained, we have to base our decisions on factual approach, which is data-driven. Now, when you don't have those informations, most partners won't want to partner with you. So if you need to do, you have to build a sustainable structure. And there is one sustainable structure I have tested, and it has worked in every sector, which is quality management system. Any organization that lacks quality management system won't have a sustainable structure that will be able to attract private and public partnerships. So quality management system is key. Whatever industry you find yourself, if you can understand it, keep to their standard and a lot of stuff, it puts everything in place. So when all things are put in place, definitely you stand in a better position to attract the desire. And a lot of other things include training. I'm an advocate of training because when you don't train people, for you to hand over things to people, you have to train them. Training is a form of armor. You arm them so that by the time you train them, you build that capacity that is necessary for them to be able to deliver. And also advocacy, like what Nigeria Health Watch is also doing. So we advocate, we speak to the people to ensure that these things comes into awareness. I don't know if I'll be able to answer your question.
Thank you, Mr. Aliyu. And I'm actually just going to move on to Dr. Anne Adaogo, who is head of policy at PISHAN, the Private Sector Health Alliance of Nigeria. So PISHAN is currently leading an impressive drive, to strengthen health security and health systems generally at national and subnational levels, but particularly the primary healthcare systems. What key instruments do you think are needed to seamlessly integrate private support and private investments into public health structures, in your opinion?
Many thanks for the question. And interestingly, I was at a meeting. There's another meeting as well on health securities that's happening concurrently, still ongoing. And speaking at that panel yesterday, it seems that we're at the right time having this conversation. It's becoming more and more important to see where there's a nexus between public funding and private sector funding, seeing how we can work better together. And that was the idea behind coming to support the Primary Healthcare Development Agency on our project, the Adopted Private Primary Healthcare Center in Nigeria. So currently, PISHAN, the Private Sector Health Alliance of Nigeria, is working on adopting one primary healthcare facility in each of the 774 local government area in Nigeria. The idea behind that is because we believe that if you can fix the primary healthcare system, the tertiary and the secondary healthcare level for healthcare will become more focused on what they're supposed to be doing, and you take healthcare closer to the people. If you can take healthcare closer to the people, what that means is you can make healthcare more affordable, you can make healthcare more accessible, you can give the people a bigger sense of belonging, you can give the people a better sense of ownership in terms of taking responsibility for their health-seeking behavior. In Nigeria, we have some of the poorest statistics, and sometimes you're wondering, why do we have some of these challenges? Sometimes it's a challenge with access, sometimes the structure is there, it's a question of uptake, it's a question of utilization. So there's the demand side, there's the supply side. The ADHFP project is working to address both sides holistically. We're working through a bottom-up approach. We know that a lot is happening at the national level, which most times has not cascaded to the sub-national level. Most times when you talk to, at the first panel session, it was clear. You talk to someone about health, he's thinking about the federal government. He doesn't look to the fact that his local government is responsible for ensuring that he gets basic health care. So the ADHFP is building a community of change through social and behavioral change communication. That's one of the approaches that we're using. We're talking to the community members early. We're empowering them. We're building their capacity to put structures in place that will help them to demand better accountability from the people who are supposed to make sure that this system works. That's the local government chairman. We're teaching them to look, beyond the federal government to what is available within their communities, to come together to be able to articulate what their health needs are. Nigeria is a very diverse but very interesting country, where you have different situations across the different geopolitical zones. So we're bringing people to have a conversation with the state primary healthcare, local state primary healthcare development agencies, with the local government authorities, to be able to articulate what their health needs are. So beyond just putting the basic primary healthcare standards in each of those 774 local government area in Nigeria, we want to be sure that we're responding to the real needs. We want to be sure that people feel a sense of belonging. And the way we're doing that is the bottom-up approach. We're also collaborating with a lot of stakeholders across the states, particularly at the local government level, because we have sustainability at the back of our minds. We know that the project is just going to last maximum for 5 years after we've adopted each of the primary healthcare centers. So how do we ensure that beyond what we have established, people continue to access healthcare? People don't go back to the poor statistics that were in these communities. So we're carrying them along. We're looking at other stakeholders. We're also looking at community empowerment, because besides establishing a healthcare system, you don't do that vertically. Health is integrated, is determined, affected by the other social determinants of health. So how do you create the nexus that ensures that the population is resilient, the population looks beyond the project, and you have a holistic approach to ensuring that through health promotion, health prevention, you are able to reduce what people are spending on treatment and rehabilitation. That's the manner of approach that Private Sector Health Alliance is using for the 774 primary health care that we're adopting across the country.
Thank you so much. That was really insightful. But so as you engage with stakeholders and you employ the bottom-up approach, what key policy instruments specifically, or legal instruments, do you think are needed? Because I know that you mobilize resources from private sector stakeholders, right? And then you use those resources to support public health institutions. Are there key policy instruments, legal instruments that could help make that process seamless for other private sector organizations looking to do the same?
Okay, thanks. What we found out as we work is that we do not lack for policies. We have robust policies. What we have not done very well is to ensure the interconnectivity between the national and the subnational level. What we also have not done very well is to ensure ownership at the subnational level. So you want to have a conversation at the national level. You want to bring the subnational into the room. You want to ensure that there is an understanding of the national by the subnational. That way, they can run with the vision. Beyond understanding, you also want to ensure that it aligns with the priority for the subnational, because different states, different local governments have different priority. So while we might be talking clean energy at national level, at the subnational, at the state level, that may not be what their priorities are. That may not, they may be dealing with an issue of flooding. That may be their immediate reality. So how do you connect the dots to ensure that the local government speaks to the state level and the state level speaks to the federal level? That's a very important conversation that people need to have. States also need to be encouraged to be participatory in the process of decision making. States also need to encourage local governments to be participatory in decision making. Beyond being participatory, it's important that the political will is there to enable that these policies are actually implemented. Outside of the political will, it's also important that you commit resources. You're not going to have private sector driving a cart that government is not interested in. So before you ask someone to come help you build, you must be ready to commit to the building process. You have to have policies that do not somersault with every government. There has to be stability where people can be assured that the environment they're making the investments in will continue to support the business that generates the revenue that they're going to invest in the sector. So these are conversations that government at all levels needs to have with private sector.
Absolutely. Thank you for that insightful contribution. I mean, one of the things we saw happen during COVID was the 50% tax cut for, private sector organizations who supported the COVID-19 response. And I think that was definitely a really good incentive for private sector collaboration.
Also to add that it's important that we build trust across all levels. Right now, there is mutual suspicion across all divides. Government really does not trust the private sector because it looks as if the private sector are in it for the profit they're going to make. Private sector does not trust the accountability mechanisms that government has put in place. So if the partnership must work, it's important, and that's one of the things that we do as Private Sector Health Alliance. We're trying to build that trust. COVID worked very well because there was a certain level of trust. There were accountability mechanisms that were put in place to ensure that funds were not diverted. And that way you could encourage private sector to keep investing in a cause that was worthwhile.
Thank you for that addition. I mean, it's not such a bad thing that private sector is, concerned about how much they would make from it. That's why they exist anyway. Like we saw with the revolving fund, the accountability mechanism was a very big encourager for private sector organizations like Dangote Foundation to contribute to. So definitely something we should be looking forward to doing and institutionalizing as we sustain the gains from COVID-19. So I'll come to you, Dr. Mokudu. Society for Family Health is one of the key health partners in the Nigerian health sector that supports, a variety of programs both at national and subnational levels. What key learnings would you like to share on how, private sector or public-private partnerships specifically can be used to strengthen health security at all levels?
Thank you very much, Kemi. I think my starting point is to say COVID was really big. So in some way, it's an extraordinary view to health security. And we must always keep that in mind because it sort of practically made health security a business imperative. And so some of the response we saw must be situated in that context. And therefore, if you're looking at the sort of variety of health security threat we deal with daily, the response will tend to vary. But sort of moving forward in looking at sort of the public-private partnerships and how they made a difference and our take on it, I think we were privileged to work across the different sort of structures put in place from the EOCs to the various sort of coordinating unit. And I think just drawing inferences from sort of our perception would be the idea of building on comparative competence was something that I think played out really well, that the sort of government knew its strength and knew where the private sector strength was. And therefore, the basis of constructing that partnership was to draw on those strengths and to recognize those strengths differently. So that was a major plus in terms of looking at it that way. But I need to also sort of put in place, for example, as an organization, SFH, we've also been privileged to actually, as part of LAFIA, implement a JEE now at state level. And it's quite reflective that some of that sort of energy that was sort of out there during the pandemic or the peak of the pandemic is clearly fizzing, sort of going away. And that sort of raises the issue that we need to do a lot more in terms of how you embed some of the principles around the whole concept of private-public partnership. I think for us also as SFH, the other sort of reflection is often the conversation around private sector can be very much around the very formal, very organized private sector. But the vast majority of Nigeria, if you were to look at the data, about 65%, actually get care at what we call the informal sector. So you are talking the chemist man in your village, who is likely to be the point where your brother, your father, your sister is likely to get care from. You are talking about the community pharmacy. It's a whole different realism there. And strangely enough, with the pandemic, those were points that became really critical when you were looking at risk communication. Because for the average Nigerian who had a cold or a cough, he or she is likely to present at that level. And so some of the work we did, for example, was really looking at how do you take risk communication really down to where it matters in terms of those community structure, trying to get them plugged in, trying to make those differences and sort of scale up. But again, like I did mention, coming a couple of months later now, looking at a JE in a few states, we've done those, and say, oh, by the way, if you were to construct your whole system around how you sort of look out for threats, how you respond to those threats, how you prevent those threats, you find those structures are fast again receding. So something to reflect about even as we look at the concept of decentralization. And I think the other sort of core element around public-private partnership from our end was I would say the broader definition of private sector that you would sort of naturally get. And I think that was really, really critical in terms of building the groundswell. Typically, private sector is seen from a resource mobilization perspective. I think in this context, we're actually privileged to see a broader application of, or at least recognition of what the private sector can bring on table, ranging from even the surveillance aspect to laboratory, which my colleague had talked so extensively about, to even looking at data, the idea of big data and what you do with big data, and the role of the academia, some of the very excellent work that was done. And so these are some of the, I would say, major pluses, but also looking at what we need to do, sort of pushing forward.
Absolutely. Thank you, Dr. Mokudu. And seeing as you touched on laboratory, I'd actually like to come back to Mr. Aliyu Israel. How do you think that we can seamlessly, because, the private sector is, like we've all said, is really vast with a lot of capacity, and you spoke specifically to how those capacities were built during the COVID-19 pandemic. So how do you think that the capacity of the private sector can effectively support public health response during pandemics going forward?
Okay. In terms of support act should be continuous, should be evolving, and should be creative, and should be innovative. Now, first of all, we need to identify the gaps that we have. Now, so some of those gaps include basically our local production. We had issues with local production where every of the things we have, consumables, reagents, we have to import almost everything. So if we have the private sector who are positioned to such a way that, because it doesn't have to be just be testing. Just imagine the number of COVID testing we did in Nigeria. And if a private sector has just 10% of the production, that is really, really huge. And that's why you see China, their GDP did not go down because of the production level at that particular time. So we were just, most of the things we were doing, trying to respond, we were consuming at that particular time. So if we begin to look at the perspective of production level, we get expertise over a period of time, you see that the support will be massive, the support will be long-standing, and the support will be definitely crucial to what we currently do. So those are one of the aspects that is really anchoring at this moment that we need to really look at as a country.
Yeah, I like what you said about production. I mean, it's not even a secret. I mean, everyone knows how much our production capacity needs to be improved. And I like what you said about gaps. And this is why, the joint external evaluation needs to be conducted at all states, so that we can identify those gaps. When the gaps are identified, then it'll be very easy for private sector to then plug in and fill some of those gaps. So I'll come back to you, Dr. Agogo. So what are your views on public-private partnerships and how they can be leveraged at subnational levels? I've already spoken to, the subnational JEE, but please share some of your thoughts.
I'm sure Mrs. Ilori is as excited as myself when you are talking about subnational level evaluations, because this is a brainchild of NCDC working with Resolve over a few years. After doing the national JEs, it was clear that the weakness of our system or the strength of our system is dependent on the weakest link at the country level. So all that we talked about earlier about, the ports of entry, for instance, if you have one port of entry that doesn't work, then you are vulnerable. And I think, so it's really exciting to hear everyone buy into that idea, the idea that, we should be looking at the subnational level preparedness. So the whole idea of the preparedness was really looking at, the JE tool, which was now domesticated and redesigned based on the mandates at the state level. So because of the concurrent list, there are certain aspects that was covered by the JE at the national level that are not really relevant to the state level. And I think the experience of conducting JEs in the initial 3 pilot states, and of course with, just like Dr. Edogo said, with LAFIA and other partners who are coming on board, and WHO and so who are coming on board to see the need, it is beginning to be clear that each state, even though at the national level we might be doing so well, each state has its own key challenge. And also each state, as you do the assessment in each state, you see that there are gaps that are peculiar to the state. And therefore, in the next, I said earlier at the beginning of the conversation that we should move it to the next stage. So after we did the national national JEE, the country developed a national action plan for health security. So really the conversation should be, well, yes, state health security assessments are essential, but after that, what next? So it's about, do we now develop state health security assessments jointly, not just hanging at the national level, but in a way that brings together the learnings from COVID. So what does the private sector have to contribute? And that includes, just like Dr. Edogo said and other colleagues have said, it includes the labs in the state. It includes the manufacturers of things in the state. It includes the hospitals in the state. It includes also the local government chairmen. So the design of the state action plans, which should be the next stage, should be one that we look at a broad-based, simple, affordable, customized approach for each state that blocks the gaps that are peculiar to the state. The other point that I'd like to make, maybe just as a rider to that, is really beginning to rethink what we think about what surveillance means. I was talking to Patrick a bit earlier to say that, and the work that's been done over the years with building the field epi programs, that a successful surveillance system is invisible. If you have a functioning surveillance system, then it's invisible. It means that you are addressing the threats even become a fire, and that's a problem in a way, because your success means your invisibility. And so we need to look at how do we now rebuild systems. And that's where the idea that health security is not an idea that stands alone. Talked about nexus. It's a nexus of universal health coverage. It's a nexus of health system strengthening. It's a nexus of primary healthcare systems. So as we build our systems better, we will have a better and stronger surveillance system. And one last point is also rethinking when we build initiatives, not to put my sister on the spot, but the 774 LGAs that we're adopting, those are potentially great sentinel surveillance sites that should have a full complement of surveillance tools. For instance, SOMAS should be in each of those systems. Our work in the cardiovascular disease, should be in those systems. One field epi, should be there in those systems. So we build, new models of which can be sentinels. And a sentinel is something that stands up and sees and scans the community. So if you have one sentinel site in each LGA, I think that is really beginning to redesign our surveillance system. So I'll just stop there.
Thank you. And just riding on that, I'd like to go back to Dr. Omokudu-Idogo. So what are your thoughts, particularly on how private sector can be leveraged to strengthen subnational structures, particularly primary healthcare across the states?
Thank you, Kemi. I think just reflecting on the last 2 years, we need to give some more thought to strategic purchasing. I think the idea of how government or the public sector buy service from the private sector is not that well developed. And that's reflective of the conversation around difficulty in absorption of resources. That even when the resources are available, sometimes you find that it takes a lag of a year, 2 years before those resources. And there's a history to that. Even if you go to the DRG years back to even some of the basic healthcare provision fund. So we need to rethink how and what is the basis of that partnership. And I think my colleague talked very eloquently about that when she actually mentioned we need to build trust. We need to build trust. So for me, that's the first key thing that even as we look forward, we pray, of course, that health security, we don't have health security challenge, but the week come. So how do you, does public sector, when those resources are available, both from its own resource, but also what could be generalized resource by those services broadly? So that's one. I think the second thing, again, is also looking at our whole sort of data system and the connectivity of that data system. The way the surveillance system is built now is you have the public sector and you have the private sector. There's very little connectivity between the private and the public, particularly if you add the non-formal private sector. So a lot of reflection, a lot of work really is around how you tie those together. I think thirdly, a conversation around what value on the long term, because when you look at particularly at subnational entity, I think it's one thing to mirror what happens at the national, which was really what happened. But moving forward, how do we build a thorough understanding of why it's so critical to actually have those public-private partnerships? That is so crucial. I often say that if you look outside this country, you have one health system. But it's only in Nigeria we talk private-public, private-public. And in many ways, it's a reflection of the dichotomy and our inability to actually bring them together to actually achieve a whole. And I think, fourthly, my colleague talked about in the first panel, the idea of risk communication. We shouldn't really be waiting for us to be in the war, to use his language, before we actually push the idea of risk communication. I think risk communication is something that must be an integral part of some of the demand creation systems we are building, whether they are chips in community, whether they are some of the non-formal health system. I'm aware, for example, the Pharmacy Council of Nigeria is really setting up a very comprehensive scheme now in terms of PPMV, community pharmacy. Those need to be built into their curriculum so they become a critical part of that sort of flow of information. Thank you.
So much, Dr. Idogo. Those were very excellent points. Seeing as you spoke about trust is something that has, been mentioned twice, so I'm going to mention it the third time just so everyone hears. Again, I'll come back to Dr. Anne. What has your experience been, engaging with subnational structures in your work trying to strengthen the primary healthcare system? And, what are the key lessons that we can learn from that?
I think some of the biggest lessons that we have learned over the period where we have interacted with states is that every state is unique. And in every state in Nigeria lies an opportunity. You know, a lot of times the narratives are very negative. And so there's a tendency to approach with a lot of negativity. But it's important that as private sector players that we recognize the opportunities that exist within each state. We also recognize the fact that it's not a one-size-fits-all. So it's important to continually have that at the back of your mind for every conversation that you have with the stakeholders. It's also important to recognize the strength that they bring to the table at the subnational level. And it's also important to give them an opportunity to be at the table. There's a difference between being invited to the table and being allowed to be at the table and have the conversation. It's also important for us as organized private sector, as we continue to engage the subnational, to understand that we give them the opportunity to be in the driver's seat. If there's going to be a project that is sustainable beyond the life of whatever the funders are contributing, including the organized private sector, we have strived in our engagement with them to give them the seat at the head of the table. If they are committed, if you allow them drive the process, if they have an understanding of whatever engagement you're going to have with them and whatever investment that you're bringing to the table, most times they design interventions, or you can work with them to design interventions that speak to their need. You know, when and that's first of all begins from the entry point at the at the subnational. You know, a lot of times we come in with pre-designed ideas as to what should work in the state, and sometimes we may not be listening. So they speak. And when they speak and you listen, you have an opportunity to work with, work through systems that can actually survive. When they talk and you do not listen and you do not consider their standpoint, then many times you run the risk of working alone. It's also important for us, as one of the lessons that we have learned, that there are resources at subnational level. We are not always starting from ground zero. So we give that opportunity, and resources now, most times it's not just financial resources. There is human resource, there is infrastructural resources, there are things we can tap into. When we started off with the ADHFP project, the Adopted Primary Healthcare Facilities, we had two kinds of projects. There were the greenfield investments and there were the brownfield investments. The greenfield presupposed that there was not much, that nothing existed at all at the local government level, and therefore we were going to start from ground zero. But based on the assessment that we did for the states where that are part of our pilot, our first phase, we realized that we're not starting from ground zero. So we have more brownfields. In fact, the primary health care in our pilot phase, our phase one, most of them are brownfield investments. So there is a place to start from. And most times, because we have recognized that, the work has been a lot easier for us. One thing that we have had to deal with is also the several layers of bureaucracy that exists within the system. So in trying to navigate that, we have learned that we have to plan ahead. And you have to give long-term notice if you're going to be able to meet the key milestones or the key deadlines that you have set for the deliverable for each project. So every state is different, you know, and every state in Nigeria definitely has an opportunity. And most times, while we're building capacity, we're also focusing on the positives.
Thank you. Thank you so much, Dr. Ann. So I'll just quickly come to you, Mrs. Ninyola. And this would be the last point because I realize we haven't, given time for the room to respond for a Q&A. So finally, what practical examples can you give of gaps that persist? I mean, you are one of the private sector organizations, given how you define private sector, that supports key technical areas, right? What gaps persist, and how do you think private sector can, key into filling those gaps?
Yeah, I think private sector has a huge role to play, and I think, like we've said all day here, that COVID-19, even Ebola, showed us the power of partnership. Government cannot and should not do it alone, and I feel that when private sector comes in, and I want to piggyback on something that was said here about identifying the gaps and the needs, right? So as private sector, we see that there's a need. Government has set a vision, a strategy, a plan that now needs to be implemented so that it doesn't just become another document. How can we work together to do that? How do we co-create a solution with government? I'll give the example of the antimicrobial resistance curriculum we developed for students. We've co-created it, and now we've been running it for several years now, and now we're looking at how do we embed this in the education system so that this is not something that's funded by a donor or implemented by a partner, but it's part of what every Nigerian child would experience going through school. I think that those are some of the ways to get ensure that at the subnational level you have adoption and ownership. So what we're doing with the curriculum in Lagos State is not the same as what we're doing with it in Osun State. You have to really look at the context of where you're implementing such things and make sure that, yes, while you're still aligned with the overall vision from the federal level, but it has to make sense for the state. And that's the experience that we've also had. I think another thing is private sector really is great in, beyond just funding and resources, financial resources, administration and coordination is a huge thing that private sector can bring to the table. When we look at the fund that Resolve to Save Lives is speaking about how that was created and, in a very short time became a very effective way of getting resources where they needed to be. When we look at CACOVID as another entity, there's no reason why these things can't live beyond the COVID pandemic. Why they can't live beyond this emergency time, and not necessarily just focused on funding, but again, focused on bringing people who traditionally don't have a seat at the table to that table and allowing us to sit together and look at these extremely complex global health challenges and see how do we come up with solutions that make sense? How do we move the needle forward? We're looking at our JEE scores. We know what some of our biggest gaps are. And when we have so much capacity in the private sector that is untapped, we need formal mechanisms to bring them together at the seats in front of government to work alongside. Because for me, in our experience, that has been what has made us the most effective in our work. The fact that we are right there with government. During COVID, we were embedded within, it was almost like you couldn't tell who was working for JASA, who was working for government. And it was a beautiful collaboration, and there's no reason why that can't continue to fix some of the bigger health systems problems that we have.
Thank you. You have literally just left this panel session in a really good place. I like buzzwords, and one of the buzzwords I picked up from that was co-creation. And, that speaks to the whole of society and whole of government approach that we keep advocating for One Health approach. And, it's just really great to see how those mechanisms played out during COVID-19, and we just really need to build on that going forward. One of the things I would have loved us to touch on is domestic resource mobilization and how government can be, in quotes, inspired, to match some of the investments the private sector will put in. But there's no time for that, unfortunately. So we're going to take a quick picture, and after that picture, we will then just open for Q&A. I think a lot of people have a lot of things to say, and we're already out of time. So please stand and just, Vivian, please come join the speakers for your picture. Thank you so much. Thank you, everyone, for being so patient and for engaging so strongly with all of the conversations. We're going to take very quick questions, comments. I will take the first 5 hands I see, and after that, I will just move on, if you don't mind. Okay, so 1, 2, 3, sir, 4. 1, 2, 3, 4, 5. Okay, done. 5. I'm going to apologize in advance for those whose questions I won't take, because I know people usually have, children questions in quotes when people start speaking. Please, let's start with him.
Okay, thank you very much for your presentations and the discussions. My question goes to the laboratory guy.
Sorry, your question goes to who?
The lab, Israel.
Okay.
So with the coming of self-testing and RDTs and all of that, we are going to see a shift in the testing modes and how testing is perceived. And most of the infrastructures which we have built may become irrelevant at some point. I don't want to use that word. I don't know if you're thinking of what are your plans moving forward in using all of these infrastructures in integrating other diseases and in looking at health security as a globe, as a whole, rather than just focusing on COVID, because at some point we may become obsolete with PCR and all of that, which is a lot of investments. So thank you.
Thank you. Sorry, we're going to take the questions first, then you respond, just so we don't. Toby had a question. Yes, and Adibisi, yes, I saw you. So Toby first, and Adibisi. I'm feminist too, so.
So yes, questions about human resources for health, public health workers. So at the point of health education locally, contact tracing and pushing paperwork. Let's take, for example, there was an infected case that flew into Nnamdi Ezekwe, only tested positive the second day. It would then be their local government. They would then communicate that paperwork to the airport that they may have been traveling while infectious. So clinicians wouldn't do that job. Community health workers may not do that job as well. It would be public health workers. So would the issue as far as HRH be with recruitment? Is it retainment? Is it training? What exactly would be the issue, and how can we solve that moving forward?
Thank you for that question. Please, when you're about to ask a question, just kindly introduce yourself and what organization you're speaking from. I know Toby's, a private entity, but Fritz had been introduced earlier, but just going forward. Thank you.
All right. Thank you. My name is Adibisi Adenipekun. I'm an engagement manager with Sidani Group, and congratulations to Nigeria Watch for hosting this dialogue. I have a couple of questions for the first set of panelists, and I'll just keep my comments, but just to say that the way we bleed in the time of war is largely dependent on how we sweat in the time of peace. And my questions will be anchored on that. So starting with UN, I don't know if there's any other person that can answer. What is the role of UN in mitigating the global inequities that we saw for COVID-19 in terms of the commodities, the vaccine, the PPEs? How can UN prevent such inequities going forward in future pandemics and ensure its security? Then for Dr. Morenike from Port Health Service, you alluded to the fact that when it comes to porous borders, it goes beyond health security to national security. So how is Federal Ministry of Health working with other security agencies to ensure that we firm up that gap? We really need to prepare for war, both national and health front. Then for Dr. Festus Soyinka from Ogun State, I'll be interested to know if you were able to get the state government to commit financial resources to COVID response, because Ogun State has been exemplary, right, in terms of response and even vaccination. So if you were able to get the state to commit money to the response in the state, how did you do that to serve as learning points for other states as we talk decentralization? And if not, what do you think can be done to get state governments to start committing their resources as counterpart funds to health security and health response? And then finally to the Private Health Sector Alliance, I'd like to know how the private health sector alliance work if I am from a private institution and I want to be part of that alliance, what exactly is the process like? And then for your support to the government, right? Are you supporting the states to also leverage the presence of private sector in their states? I mean, we've read about the Aliko Dangotes and everything, but how about the private sectors at the subnational level? Does your work include supporting the state government or the state's leadership to also leverage that resource that is available for them at their state level? Thank you.
Thank you, Adebisi. Now I regret saying we should postpone the Q&A until after the second panel because some of you that are supposed to respond to your questions are not here anymore. But there are, strategic partners in the room that can speak to some of the questions that you asked. Hi, Funke, you had a question. Don't worry, I'll come to you, sir. I definitely saw you.
Good afternoon, everyone. My name is Funke. I work with Just Know Incorporated, and I want to congratulate Nigeria Health Watch for this program. I want to take us outside this a bit, listening to private executives just finished speaking. I want to ask, my question is to Dr. Emmanuel. You mentioned that they have a rapid response fund for some emergencies, and as reproductive health person, we have so many commodities at the warehouse in Oshodi, and these people at the state level, local, don't even have access to those commodities. Most of them have buy stock out of family planning commodities. What can you do with this fund that can help these women to have access to family planning commodities? Thank you.
Thank you.
Good afternoon, everyone. I want to congratulate Nigeria Health Watch for putting up this. My name's Badum Samuel Johanna, the Assistant State Field Epidemiologist, Kaduna State. I'll start by looking at the JEE. The JEE was actually a good tool that put us up on our toes to meet up with the global health security agenda. And when it came up, NCDC, after we had the first meeting, and we expect probably a push, then we prepare for your second coming. And when you came for the second coming, what you brought out were things that if we had looked at those documents, would have had more scores and would have done. So the question here is, how many states have you been able to push to actually utilize that tool to look at their own health system? And then what are the challenges? Probably there could have been reason why some of us are still lagging behind. And I want to say, when you come next, of course, it will be better than what you saw. So thank you very much for that push. Then from Peter's presentation, though he's not here, we also, Olaolu, you also touched on that issue of budget line for APR. I happen to work in the privilege to work in some states in the country, northern part, Kebbi, Jigawa, and one common thing which was a bit silent here is the political will. Budget line, yes, budget line, the issue around political will. How do we get around this? How do we handle this? When I was in one of the states, a high-powered advocacy team came from the national. Well, that was in immunization. And they had a discussion with the state governor, and probably they want to see such kind of high power to support the state. Can NCDC maybe help us to push this JEE? Once you do that, one of the challenges is funding. Yes, we have funding allocation, and when you come to the state, you hear approval or release without funding. Some funny words. Yeah, the money is there. We've done all the work plans. We did everything. The money has been approved. but you hear some. So, but if a higher maybe advocacy communication team that will look at all those things and then see to it, especially with regards to global health, security, I mean, this agenda, I think we'll do more than just talking and then, but let there be a kind of a team which brings up the stakeholders at the national and push. I think we'll do more than, of course, we had a budget of close to a billion, but the implementation, you end up having only 10% and everything is just there. So that's just my concern. Thank you very much.
Thank you so much. I really enjoyed hearing some of your experiences at the state level. That's why we're here. So who wants to start? I think, okay, please go ahead, Mr. Liu.
Hello. Yeah, now, concerning the infrastructure and the equipment you talk about, maximizing it. Now, the advance of technology cannot be declined in each generation. There will always be upward advancement. However, that's why we have process optimization. Now, a lot of things we do with the, let's say for the PCRO, before the COVID are not what we actually do. We have optimized to ensure that apart from the COVID, now you go to some facilities, you now have people doing PCRO for malaria, other infections and other infectious diseases. So optimization of those platforms is one way we are currently doing to ensure that those investment does not go into extinction. And apart from that, now the private sector, we are a group of people who have health economists, health managers, risk assessors. Everybody puts their input to ensure that we're able to maximize the essence of any project or any investment that is currently put on ground in the private sector. Thank you.
Someone could like to add to that, please. Okay. Oh, the second question. Okay, please.
It's across the whole spectrum. We have a problem both with numbers. We have a problem with maldistribution. So, for example, if you look at, say, doctors, there are more doctors in Lagos than 10 states put together. So we have a problem with maldistribution. We have a problem with quality, so as you would expect in terms of competence and all that. And now we have a major problem with migration, like Dr. Oko talked about in the morning. Nationally, there's been some response. Of course, we've had things, for example, an attempt at decentralizing. So you've heard about the tiered accreditation and what we call tax shifting. So the idea is to take some elements that are done by higher cadre and see whether we can get lower cadre to do that. That's a different level of implementation. Often you find that while the contingent policy at national level may have shifted, the attendant policies that then sort of make it operational at state level, at local governments are still there. So those are some of the, so for example, you have a policy that says, oh, you can do tax shifting, but you have another policies that says this certain cadre cannot take blood. So you can't draw blood, you can't do venipuncture. So those are limitations. And I think those are things as a country we're working through. But I think just like Dr. Oko mentioned, we actually have a large problem at the moment around migration because we're really losing the very best that we have as a country, and it's something that's scary to sort of think medium, long term. Thank you.
Thank you so much for that response. So I think I'll go to Dr. Shoyinka so he can respond to the question about Ogun State.
Thank you very much. You were asking about how we were able to mobilize the support for the response in terms of specifically from, well, I want to say one thing that COVID brought was unlike other responses we had, which are local or focal epidemics, was the involvement of key individual. The governor was the incident commander. He was receiving briefing every evening. Every evening. The EOC was working out to ensure that updates were provided to the Honorable Commissioner every evening, and she must speak with the governor. So he knew what was involved. The same thing with the Honorable Commissioner, who newly came from outside the country and wanted to perform. So these were two things that drove, their involvement. And COVID also came with a lot of panic. A lot of panic from government, from private sector. So that brought us a lot of goodwill from the private sector. Ogun State is very rich in industries. So they came, through the Ministry of Industry, Trade and Investment, engaged the private sector within the state, and they came with a lot of support. For instance, before COVID, we did not have PCR facility. The first mobile PCR facility in the country was built in Ogun State with support from private sector, FCMB, to initially get us the few number of tests. Then we later were able to procure the facility with support from another private sector. And we have, other companies that built for us the 80-bedded isolation facility in Ota, and several other donations like that. Most of those things were done directly by, partners. We got also funding support, mobilized from other, sectors to respond to this emergency. And the issue of peer review and the competitiveness in the leadership. We were always looking at Lagos and wanting not to be behind. So we used that as a means of getting the governor to get committed to, more funding for things to be done. So that was some of the things that really helped us. Thank you.
Thank you so much, sir. And, you've spoken to a lot of things that I think our colleague from Kaduna State is definitely taking notes about, galvanizing political will and getting those resources allocated, which will bring me actually to the question about JEEs. And I would like Mrs. Elsie Laurie to respond to that question. Mrs. Elsie Laurie is Director of Surveillance at NCDC.
Yeah, thank you. Putting me on the spot. Okay. I think I was actually ready for that. Yes, I think there's a question on the states, pushing the states. Now, we cannot push the state because it's the state's responsibility for the health security of the people in the state. Now, what we do is we advocate with the state, and that is ongoing right now. In fact, some states come by themselves and tell us they want to do it. Now, we have done fully both the assessment and validation in 5 states, and that included Kaduna. The next stage is for the states to be ready to develop their own state action plan for health security, and that's ongoing. I know Kano has taken the bull by the horn, and they have started that process. We're waiting for the other states to take that initiative and want us to come. We will support them, but the state needs to take that responsibility. I remember, state ownership is very key, and that's what we are discussing here, decentralization. The state must own it, and so that's what we're trying to do now, that the state owns it. We're not going to go to the state and tell them what to do, but the state needs to tell us what they want to do after the assessment. And now we have talked about the how many states, and it's voluntary, because JE is actually voluntary. Even at the global level, it's a voluntary exercise, and if the state is interested, we'll do that. We have partners that have supported us. Right now, we have WHO supporting about 5 states. We also have the Lafayette team wanting to support 2 states, that's Borno and Yobe. So all those the states, it's ongoing right now. So for us, we want states to be interested. Lagos State is also taking that. We're supporting Lagos State. Now, we talked about that political will. I really want to bring this. You see, when we talk about political will, yes, they're there at the top. We need the people to demand for accountability. And accountability is not only by financing. Accountability in terms of what you have done. And we want the people That's why the communication team need to do a lot of advocacy with the communities. The people need to demand for what our political leaders have done. Sometimes they celebrate their 100 days in office. We need to ask them, what have you done within those 100 days? Tell us what you have done. You told us you were going to do 1, 2, 3. So in terms of the health security of your people, what have you done? So if we keep demanding, then they know that this is quite important and they need to prioritize. So that's one area, political will. And then, well, I've said, I talked about that the JE is voluntary. We're waiting for states to request, but we are doing a lot of advocacy in that area. And I need to commend the Nigeria Health Watch. They have actually helped us in that area, talking to the states, and we're having a lot of requests from the states now. Thank you.
Thank you so much. Okay, should like to add something?
Yeah, so I just wanted to add something to the comment that was, or the question that was asked here about the Federal Ministry of Health and whether or not they're working with other security agencies in Nigeria. Through our health security work in collaboration with ProHealth International and PHS, Port Health Services, I can say definitely that the stakeholders we're engaging at these 13 points of entry include the security agencies. So at the seaports, Navy is there. At all of the points of entry, DSS, police, immigration, customs, all of the security agencies are very much involved in creating this collaborative response structure. And it's also a bit tied to the question that you raised about if a passenger comes into an airport and ends up at the LGA level, how does that communication flow back to the airport that this has happened? When you have these kind of structures in place, it allows for everyone to have agreed. So one of the deliverables of our project is to come out with a document, a memorandum of either collaboration or understanding between the federal entities at the point of entry and the local government. We have existing structures. We have disease surveillance notification officers in LGAs, but are they aware of their mandate to report such things back to the federal level? You can't give what you don't know, right? So in addition to building their capacity, trying to embed it within a system and a structure of identification of these public health threats and also response to them. So I think that that's just one thing I wanted to add to those two questions from that table.
Thank you very much, very insightful contributions. Dr. Ann, were you going to respond to some of the questions about PSHAN? Okay, I can remind you. There was a question about how you support states to leverage private sector resources within the states to strengthen their health systems. There's a mic behind you.
So, in terms of supporting states to leverage private sector organization, first, what we do is to map what private sector organizations exist in that state. Then the next thing is to map what the needs are, because you have to be speaking, you have to be matching apples to apples and apples to oranges. We try not to push. Most states have a state implementation plan. In fact, most of them have a costed work plan. What the challenge is with the costed work plan is where to get the funding from, where to get the resource from. So the first point is, at the state level, do they have a costed work plan? Not all the states have. Some have not updated versions. So if you walk into a state, you want to know what the costed work plan is. You want to know where the gaps are. As one of the panelists say, sometimes an issue emerges and is not planned for. And once that issue emerges and is not planned for, then it can't be accommodated within the budget cycle for that year. So if there is a need, you want to wait for the state to reach out to you. So one of the first things that we have done is to let the states know about our presence in the state, so that when they, instead of using a push approach of pushing out resources to them, we use a pull approach. Now they know where we are. They also know what capacities exist within the states in terms of what, which organized private sector, which company. Most times not just for financing. Sometimes it might be for technical assistance. Sometimes it might be for mentoring. So not everything boils down to money. So once they reach out to us, we're able to build that bridge because the private sector, most of them talk to us. We also know the area of interest for most of them. So what we then do is to act as a bridge between the state and the particular private sector that can speak to the issue on the table. So that's how we support.
Thank you so very much. And coincidentally, we have an MOU with Pishan. Just going to put that out there. We're really looking forward to the kinds of collaborations that would, definitely, increase the impact that we would have across the country. And this brings us to the end of the session, both the panel session and the Q&A. Thank you all so much. You've been a very engaged group of delegates. And with that, I would like to welcome Vivian Ihekweazu, the MD of Nigeria Health Watch, for the closing remarks. There is lunch, so please don't rush off. Please put your hands together for my managing director.
Okay, wow, it's been a very busy morning, and really it's difficult to summarize so much that has been said, but I think the first thing I need to absolutely say is thank you ever so much to our panelists, I think, and speakers. There is so much that you've shared, and when we first started the discussions about decentralizing health security, as I mentioned, the reason why we feel this is so critical is that absolutely COVID-19 showed us that health really starts at the community, at the local level, and strengthening those structures will support any national response that we have. A lot was said in terms of health security begins with universal health coverage. If we do not strengthen our primary health care centers, where most Nigerians should seek care, we really are struggling. If there's an infectious disease outbreak, the first place that should be noted is really in the community, at the PHC level. And we were really pleased early this year when MPHCDA, through the Ministry of Health, held that PHC dialogue. And really, we all know that if we get primary health care right in this country, so many of our health challenges, be it the most common reasons why babies die, diarrhea. We talk about health security. We talk about immunization. We talk about SRHR. All of these issues really start from strengthening primary health care. And Peter alluded to the importance of financing and accountability. We talk about the amount of money that was released for the COVID response. And through for instance, with COVID, there were very strong accountability mechanisms because there remains that disconnect between private sector and public in terms of trust. If the private sector, releases funds, as we saw through COVID, how do they know that the money would be efficiently used? How do they know that, on the other hand, the public sector look at the public sector as there for just making money? We all know that private sector organizations are there to make profit. However, we do know that they have a lot of capacity that can be leveraged to support public health responses. So without summarizing everything that was said, because there really was a lot that was said, I think Ninyola spoke very much about border control. We take it so for granted that, ports of entry are just airports, but our porous borders also remain a challenge. And without the collaboration and coordination between different agencies, these vulnerabilities will persist. So much, I think, as a country, has been learned. There are many areas we all know we kind of did, as a country we did well on. I think many countries in the global north thought that many African countries would struggle with COVID. There have been many deaths. We are cognizant of that. We're not over. COVID-19 is still very much with us. But COVID-19 is with us against the backdrop of all the other health challenges that we face as a country. And I think all of us in this room are completely cognizant of these health challenges. And I think just to summarize, just to finalize what Mrs. Ilori said, political will is critical in terms of the leadership supporting all these health interventions. However, until we have Nigerians actually demand for health, not just demand, but know they have a right to health and have the voice and the platforms, more than anything, to make that demand heard and taken seriously. We're currently doing a community health watch project where we're looking at primary healthcare centers in 2 different states. And we all know when we look at those that nobody would want even their worst enemy to seek help from those communities, from those primary healthcare centers. But until those communities have a voice to know that they have a right to demand better healthcare from their local governments, etc., we will continue talking to ourselves. So I think in a lot of the work we all do collectively, we have to remember the communities need to be empowered and provided with those platforms to demand for better healthcare. With that, as Kemi mentioned, it's lunch. I'd like to also thank our brilliant moderators, Dr. Ifeanyi Sofa, who did the first panel session, and then Kemi, who also did the second panel, and also was a brilliant moderator. So thank you very much, Kemi, for holding together all these different sessions. And of course, thank you so much to my brilliant Nigeria Health Watch team. You guys always show up every time and always do this great work, and really appreciate the teamwork in doing it. And of course, to all our delegates who came in person, and also those who logged on online. Just final plug, our Future of Health conference this year is on the political economy of health, and I think it's apt, given that we are in an election year, and given, as we mentioned, the importance of political will and citizen advocacy for better healthcare. So without further ado, once again, thank you ever so much, and I will leave you all to get on with the rest of your day. Thank you.
Nigeria Health Watch is a non-profit health communication and advocacy organization. We engage and support the government to raise awareness and increase engagement on a wide range of health issues. Since our inception in 2014, we have provided informed commentary and in-depth analysis of health issues aimed at advocating for better health care for Nigerians. Our unique capacity lies in our communication expertise using a wide range of tools including print, TV, radio, and social media to enable our advocacy efforts. We have used our convening power to organize health policy dialogues, bringing together policymakers and health experts to offer solutions to the many health challenges in the country. Our evidence-based communications and advocacy has focused on health issues ranging from maternal newborns and child health, routine immunization, epidemic preparedness and response, universal health coverage, and nutrition. We have worked with the following development partners. We remain focused on meeting the health information gaps and needs of health professionals and the population in Nigeria.